The committee will come to order. The Oversight Committee exists to secure two fundamental principles. First, Americans have a right to know that the money Washington takes from them is well spent. And second, Americans deserve an efficient, effective government that works for them. Our duty on the Oversight and Government Reform is to protect these rights. Our solemn responsibility is to hold government accountable to taxpayers, because taxpayers have a right to know what they get from their government. It's our job to work tirelessly in partnership with citizen watchdogs to deliver the facts to the American people and bring genuine reform to the Federal bureaucracy. It is our mission statement, and it is our calling. Today, when we discuss, once again, HealthCare.gov rollout, which has undeniably been and inarguably a disaster. It is not a disaster of the making of one man or any one person. In fact, in many ways, it is a sign of a failed system that is often seen in the Federal Government and very often seen by this committee. Nearly 2 months after the Federal website launched, even as the Administration declares its vast improvements, components of the back end are still unfinished. Customers are told that at least in some cases, many cases, their applications may not have been correctly forwarded to the insurance carrier, meaning they've signed up, they're not going to get the benefit. They may go to the hospital and not be covered. Or if they're covered, it will only be after weeks, months, or years of paperwork. Additionally, it is now learned that the ability to properly pay insurance companies is in doubt, and as a result, estimates are likely to occur. Estimates are not how you do business. The project's failure raises serious questions on what hindrances government faces when it intervenes in the private market. President Obama wisely said that business startups often have these sort of problems, that these are the nature of private sector startups. The difference here is the private sector wasn't just starting up, the private sector was fully up. Rather than leveraging the private sector, HealthCare.gov essentially built a whole new layer, a whole new decision process on top of it. Before October 1st, the President told Americans that purchasing insurance on HealthCare.gov would be as simple as shopping for airfare at Kayak or Expedia. I've shopped at Kayak and Expedia. The only difficult thing at those sites is choosing from many choices, well-defined, and making your decision. In fact, nothing has been more different than Kayak or Expedia at the site. Just yesterday, I logged in to the D.C. exchange, where members of Congress must go, and got an error. We do not have either the front end or the back end, not just in the Federal system, but in systems that feed into it, in fact, ready. Can anyone honestly imagine what would happen if you went to buy an airplane ticket on Kayak or Expedia and the site constantly crashed, losing your information? Or, in fact, if they told you, leave your personal email and we'll call you back in 8 or 10 hours, or email you back in 8 or 10 hours, in order to tell you that it's now a better time to try to log on and find prices. HealthCare.gov is a monopoly. HealthCare.gov is a mandated tax end location. For members of Congress, they will either go to HealthCare.gov or they will be without insurance and be fined. Yet today, no one has been held accountable for spending hundreds of millions of dollars in taxpayer dollars on a website that simply didn't serve the President or the American people on his signature legislation. As someone who spent many years in the private sector, I know that if I'd ever staked my business on a product that performed like this, it is unlikely I would have gotten a second chance. In fact, if a company launched like this, they would have to go back down, regroup, remarket, and relaunch. But that is not the case. Most of the laws stay in place, most of the enforcement stay in place, and as many of the other committees are looking into, Many of the exceptions are not ones which are codified in law or within the purview of the administration to decide to forgive or delay. More importantly, the failure of this website, some $640 million invested, will undoubtedly cause a loss of revenue many times that. The actual exposure to the vendors and the individuals may be limited, but to the American taxpayer, it will be billions of dollars of lost revenue because of this failure. I did not vote for the Affordable Care Act. I do not believe that it will drive down the cost and up the availability and affordability to the American people. However, getting the system under the law to work as well as possible and then having a discussion about how to improve health care for the American people is our responsibility. Today we are joined by Dr. Clifford Winston of the Brookings Institute, who wrote in 2006, "Government failures appear to be explained by a short-sightedness, inflexibility, conflicting policies of government agencies." I might note that 2006 was before President Obama was President. As Senator Obama, this was not about his government. This was about the government of his predecessor. Health care was broken before President Obama came. By its very design, the Federal Government may never be efficient or effective or innovative enough to carry out big initiatives like Obamacare, nor should it be. Government should not be picking winners and losers precisely because it is proven to be so bad at it. More importantly, America is a free market country, and the free market has worked for the American people time and time again. Americans know that when you close off and create an artificial monopoly, it costs more. It always costs more not to have competition. But in fact, that's what's happening in health care today. Half of health care costs to the Federal Government reflects the entire cost of defense. Defense is not something we can outsource to the private sector. Health care is something that has always been within the private sector and should be. We can hire the best and brightest, as administrators have boasted, and still end up with a product that arrives delayed and not working properly. There are things that are inherently governmental, and this committee will always be absolutely determined to defend the responsibility of government to do what is governmental, procurement certainly being one of them. Protecting our homeland, securing property rights are just a few of the others. But something as complicated, as complex, as multifaceted as a web portal supposed to rival sites like Amazon.com for health care is something the Federal Government clearly was not prepared to take on and do properly. Government inefficiencies are not limited to massive interventions in the health care industry. However, as this committee, which has voted on a unanimous and bipartisan basis the reform of IT procurement, has discovered, we need to make major changes in how we do procurement. We also need to do what is inherently governmental and leverage the private sector to the greatest extent possible. The hearing today will go a ways toward understanding what government can do, what it cannot do, what in fact should be expected by our government, and what should be expected to be innovated in the private sector. The limitations on big government will never include preventing waste in a massive scale. It will always happen, and this committee will do everything it can to reduce it, to organize it, but I believe that in fact we have before us an example of something that may be too big to swallow even for the U.S. Federal Government. And with that, I recognize the Ranking Member for his opening statement.
Thank you very much, Mr. Chairman, and I welcome our witnesses here today. And I look forward to an informative and spirited discussion. I must say that, Dr. Thomas, I had an opportunity to read your testimony, and I think it's appropriate that I start off by just quoting a little bit of it, because this is reading that every single American and every member of Congress needs to read. It's some of the best testimony I've read since I've been in Congress 17 years. It says in 1900, a newborn American citizen had a life expectancy of 47 years. A heartbreaking 10% of all infants died before their first birthday, and infant mortality was far higher among the rural and urban poor, whether on southern farms or in northern tenements. By contrast, an American born in 2000 could expect to live 75 years, and infant deaths have been cut by 93%. You go on to say, in all these areas of medical and public health progress, the Federal Government has played a fundamental role as both sponsor and coordinator of a remarkably concerted effort involving communities, states, organizations, and institutions across American society. The Federal Government, therefore, deserves a great deal of credit for doubling life expectancy for Americans, as well as for tackling a long and ever-changing list of problems regarded as the worst enemies in the nation's health, from tuberculosis and polio to cancer and AIDS. According to the Chairman's invitation letters today, the committee will examine the institutional limitations on the efficacy of government action. And our case study will be the rollout of the HealthCare.gov website. The fundamental presumption underlying this hearing is that the Federal Government is somehow incapable of successfully administering large-scale programs. In fact, the Republican staff briefing memo challenges, and I quote, government's ability to effectively design, implement, and administer large-scale projects and programs, end of quote. The problem with this presumption is that it does not take into account many extremely successful government programs that have helped millions of Americans throughout our history. In 1935, President Roosevelt signed into the law the Social Security Act, the centerpiece of our Social Security safety network. When it first launched, critics panned its confusing procedures, and less than half of the labor force participated. Over time, however, it has reached 90% of American workers and has been expanded to cover the self-employed, to include dependent and survivor benefits, and to provide for cost of living adjustments. 30 years later, in 1965, President Johnson signed Medicare into law. Like the Social Security rollout, there were challenges initially, and the American Medical Association called it, and I quote, the beginning of socialized medicine, end of quote. The Federal Government had to negotiate with hospitals, nursing homes, and insurance companies, and it had to coordinate with all 50 states. Eventually, 93% of eligible seniors enrolled in Medicare, and the program has been expanded and improved several times since then. 40 years after that, in 2005, President Bush signed into law the prescription drug program on Part D of the Medicare law. I said D. Like Social Security and Medicare before this drug program also experienced challenges in its rollout. Newspaper headlines were dire, stating, quote, confusion reigns over drug plans, end of quote. Quote, not ready for prime time, end of quote. Quote, prescription drug plan Part D gets an early F, end of quote. In all of these cases, early setbacks were resolved. Critics were proved incorrect. And these programs are now immensely popular with the American people. But more importantly, they prevented our nation's seniors from dying penniless and homeless. They provide a basic level of security to the American people where the private sector failed to do so. But it also provides something else. It's called dignity. The same is true of the Affordable Care Act. The private insurance market discriminated for decades against people with pre-existing conditions. Insurance companies threw people off existing plans when they discovered evidence of previous illnesses that patients themselves did not even know about. But now, thanks to the ACA, millions of Americans who could not get health insurance in the private market now have access to it. In terms of today's hearing, I think everyone understands what is going on. The Republicans want to use the initial challenges with HealthCare.gov website to make a broader argument that the Federal Government cannot administer large-scale programs effectively and that we are all better off leaving it to the private sector. But we have tried that, and it simply does not work. I believe the premise for today's hearing is fundamentally flawed. Our country's experience with Social Security in 1935, Medicare in 1965, and the prescription drug program in 2005 demonstrates our government is fully capable of overcoming initial problems with the implementation of programs that help millions of people in their daily lives. I remind all Americans that we are a can-do nation. We are a can-do nation, and we're better than that. This premise becomes even more absurd when you look at our nation's broader history. In the 1940s, we mobilized our entire country, our people, our industry, and our workers to defeat the Nazis and the Japanese in World War II. In the 1960s, we tapped the best and brightest minds in government and the private sector to build a space program that put a man on the moon for the first time in human history. Our government does not always work as well as it should, but it's certainly capable of great things when there's a strong commitment to the underlying goals we all share. In the case of the Affordable Care Act, we know that one component of the rollout, the HealthCare.gov website, did not work as it should have. But we also know from testimony before this committee that another component, the complicated interagency data hub that most experts worried about, worked much more smoothly. And that is a testament to the strong work of the agencies and contractors involved. As I close, as we go forward, I hope that we can work together to solve any problems that arise in order to improve the program so that it works effectively and efficiently. It's not about who we fight against. It's not even about who we fight with. It's about what we fight for. What we fight for, and this moment is greater than this moment. It's about generations yet unborn. In that way, we can honor the commitment we made in the Affordable Care Act to help people who could not get health insurance to attain it now. Mr. Chairman, I look forward to today's hearing, and I thank you for calling it.
Thank you. All members may have 7 days to submit opening statements and other extraneous material for the record. We now welcome our distinguished panel of witnesses. Dr. Dr. Derugi, I always get your first name. It's a lovely name. This is not the first time I've had trouble with it. And we have, obviously, Dr. Winston, welcome. Dr. Clifford Winston, Dr. Derugi is Senior Research Fellow at the Maquedas Center at George Mason. Dr. Clifford Winston is a Trust Senior Fellow at the Brookings Institute. Dr. Mark Calabria is the Director of Financial Regulation Studies at the Cato Institute, and Dr. Karen Thomas is a historian and communications associate at Johns Hopkins Bloomberg School of Public Health. Welcome. Pursuant to the rules, would you all please rise and take the oath, and please raise your right hands. Do you solemnly swear or affirm that the testimony you are about to give will be the truth, the whole truth, and nothing but the truth? Please be seated. Let the record reflect all witnesses answered in the affirmative. In order to allow time, without objection, your entire opening statements will be placed in the record, and I ask you to observe the lights in front of you and limit your time to 5 minutes. Dr. Derugi.
Chairman Issa, Member Cummings, member of the committee, it is an honor to appear before you today. While the nation is focused on the day-to-day problems related to the ACA's rollout, these are only the most recent and visible signs of the fundamental flaws that plague government intervention in general. My testimony will focus on why government intervention is often doomed to fail, and it will illustrate this point with the example of a specific loan guarantee program. The idea that government fails shouldn't be a surprise to anyone who has read the academic work of public choice economists, such as Nobel laureate James Buchanan, George Stigler, or Vernon Smith. Their work has explained why, despite good intention and nearly unlimited resources, top-down solutions not only fail to address the problems they're trying to address, but also sometimes and often makes the problem worse. There are many reasons for this, but I would like today to highlight two of them. The first one is that even with the best of intention, the incentive of elected officials and bureaucrats to prudently manage taxpayers' money are very weak. They are not rewarded when they maximize consumer value, nor are they necessarily punished when they take unnecessary risk or fail to minimize cost. In fact, no one in government, so far as we know, has been fired over the problems with the ACA website. Meanwhile, private companies that misstep are quickly replaced by better competitors. A key reason for these poor incentives is that government actors all operate within limited knowledge. While individuals acting in markets are able to use price signal to guide their decisions, government decision makers have no such guides. Hence, they have no way of accounting for the value or cost their decision might create for others. The second reason why government often fails is that interest groups are able to exploit this environment to obtain their own goal, often at the expense of the public welfare. And for this, you don't have to go to look further than the sugar lobby and the tariffs and subsidies they're getting and the increased price of sugar that they impose on all customers. The bottom line is that in government, intentions do not equal results. More importantly, this is true no matter who is in power, and it is true across many government programs, not just healthcare. The Department of Energy 1705 loans program is a good example of the gap between what a program's proponent claim it will achieve and what it actually does. This policy was put in place under the claim that renewable energy companies do not have access to sufficient credit to support new projects. These alleged imperfections of the credit markets, we are told, are particularly important for small and innovative companies. However, when you look at the data, what you find is that nearly 90% of the 1705 loans go to projects that are backed by large and well-connected companies such as NRG Energy or Goldman Sachs. So in that sense, it's very hard to argue that the loans are going to small, innovative companies that wouldn't have access to credit if indeed their project was viable. This program is also a good example of government favoring two distinct interest groups. First, the bank, because the lenders now don't have to face the risk of lending money to a company that may default. And second, the companies that are now benefiting from very good rates and good borrowing conditions, especially if compared to their competitors. The taxpayers, on the other hand, bear the risk and shoulder the burden when companies like Solyndra or Abound Solars default on their loans and when they go under, right? The other losers in this case, of course, are the companies in that same field who now do not have access to credit, even though they have viable projects, because all the money tends to go to companies that are backed by government guaranteed independently of the merits of the project. In addition, like most government intervention, these programs, and of course exponentially larger program interventions such as the healthcare law, create serious and systemic distortion in the market. However, the tragedy is, despite evidence, lawmakers often don't get rid of inefficient programs. And that's because they're more likely to respond to the pressure of vested interest groups than they are to actually try to protect taxpayers who very often don't even realize the cost of these programs, whether it's directly or indirectly. Now, there's good news. We have over 6 decades of research on government decision-making to help guide policy decisions going forward. In many cases, a sensible solution is simply to leave some activities outside of the government purview. This is not a loss, but a gain for government. Not only will it prevent the type of government failures that I've been talking about, but it will also allow the government to focus on its core function. It's like the provision of public good and the protection of property rights. Thank you.
Thank you. Dr. Winston.
Thank you very much. I'm very happy to be here. Chairman Cummings posed a very challenging question. He raised the issue about successful government interventions and government projects. And it's challenging because the issue is, how do we determine success? What's the benchmark that we use for success? And if government does not achieve that benchmark, how should we proceed? So my testimony is really trying to shape that framework and give us some information about what we know about success, the evidence, and alternative ways to proceed. I'm an economist, so I'm going to follow the way economists do things. First, outlining the theory of why government intervenes in economic life, what it's trying to do and what it should be doing, and what the empirical evidence is on its interventions. And then, given the motivation of this session by the ACA, I'll try to draw some basic implications. All right, the theory. Government intervenes in economic life for two reasons. One, to correct a market failure, monopoly, externalities like pollution. That's what we mean by market failure. The other is to pursue a social goal. The market is efficient, all right? There's nothing wrong with the market in terms of its allocation, but the public doesn't like the allocation that exists. Okay, so we want to do things like reduce poverty. All right, third issue is macro. We're not talking about macroeconomics here, thankfully. Market failure involving large projects. Where do things go wrong? One, they're simply not supplied. They're not privately profitable, even though they're publicly, socially desirable. Okay, or there's free riders, and so there's an undersupply of that kind of project. Government's role then steps in and tries to provide the project, but has to do it efficiently. And when I mean efficiently, I'm talking about it prices it right, makes cost-benefit assessments and investments, produces the project at minimum costs, and provides technological advance. What are social goals? Well, the social goals we're talking about here are what we call merit goods. These are goods and services American society believes that everyone should have, regardless of whether they can afford them. Social insurance is obviously what we're talking about in this case, coverage for health care. Okay, these usually involve some sort of redistribution. You're going to be taking some resources from some people, giving them to another. This is something, though, that is a democratic decision. That's fine, but it should be done at minimum cost. So there's still an assessment there. Market failures, you look at trying to maximize efficiency. Social goals, you try to minimize costs. So what is the evidence that we have on how well government has done on this? I go through this in detail in my written testimony. What I can say here in the areas that I've done a lot of work in transportation, anywhere from highways, airports, air traffic control, inland waterways, urban transit, passenger rail. Probably as I even say these things, you're beginning to think of the symptoms: congestion, delays, budget deficits. So these actually are symptoms, and they're symptoms of the economic inefficiencies: mispricing, poor investment, production cost overruns. These are all familiar, but these things total up to hundreds of billions of dollars of costs. And of course, there are other things that we can see as inefficient. All right, so the question is, how can we improve government in these areas? Social policies are not really my area of expertise, but I think it's pretty much well known that Social Security, Medicare, and so on, regardless of whether they've certainly been established, and they have, are they achieving their goals at minimum cost? And obviously that's a high standard, but I think that's really what we're looking at. How can we do these things more efficiently? All right, so faced with evidence of government failure trying to correct market failures and pursue social goals, what's the explanation for this? And it's actually already been given by the chairman. Certainly agency limitations, technical expertise, and a culture where you don't provide the kind of retro assessments to sort of correct where you're going. Regulatory constraints. What I found interesting about the ACA matter was actually a provider offered to do the website at no cost, but was told he couldn't do it because of regulatory constraints. Okay. Political forces, obviously, stakeholders, and it's a big part of what public choice is. So there are well-known reasons for failure. What now do we say, pulling this all together for ACA? I think the lessons are there were predictable concerns in rolling out the website: technical issues, lack of ongoing assessment, inflexibility, and various constraints. I think obviously the full story hasn't been told yet, and we'll see other explanations, but I'm sure that it'll have a familiar ring to it. The question, though, is the key point of what I'm trying to get at. Too much of the discussion has been attacking ACA and indirectly the social goal of universal coverage. To me, that's off the table. That has been decided by the democratic process. The President's been elected and reelected on that position. All right? That's how that has to be decided. The analytical issue and the policy issue, though, is achieving that goal at minimum cost. That is what we ought to be talking about. How can we do this more efficiently? We're already seeing ways that some states are doing it in a better way than others. We should certainly be open to that. But I would also say, too, that we can certainly be open to the private sector having greater involvement.
Thank you, Dr. Whitson. Dr. Calabria.
Chairman Eisler, Ranking Member Cummings, and distinguished members of the committee, I thank you for the invitation to appear at today's hearing. Let me first commend the Chairman for calling today's hearing. All too often in Washington, I think we can sometimes get lost in the details of policy and forget some of the basic principles. So I do think that today's hearing offers us that opportunity. Academics and practitioners have long recognized that governmental action faces a number of institutional limitations. I would be very clear, these limitations don't change with the party in control. They don't change with the personalities and competencies of political appointees. Certainly, I think anybody could look at, for instance, the response to Hurricane Katrina or the initial rollout of the Iraq War and say that these things did not go smoothly. This is not an issue of party. And of course, these considerations should always be taken into account. And I think we always should keep in mind that while government is capable of great good, it's also capable of great harm. And I would also say that, unfortunately, it seems to me that often the attitude in Washington is we must do something, when leaving that option to the private sector should always be something that should be considered. I also want to be very clear at the beginning of my comments that nothing I say is meant to imply that markets are perfect. Quite frankly, I don't know of any human institution that's not flawed to some degree, so it's always a choice of flawed institutions. I will note, however, that to me the first limitation that government lacks is the powerful feedback mechanisms we find in the marketplace. Private businesses can rely on a small number of signals, such as sales volume, prices, to determine their success. By contrast, government programs can spend millions, even billions, without any clear signal of success or failure. For instance, few of us would debate whether the iPod or the iPhone has been a success. I think we could all agree on that. But economists continue to debate whether the New Deal actually ended the Great Depression or not, and economists debate whether the 2009 stimulus created jobs or not. In some degree, these are inherent in the nature of these programs. Certainly, government programs, social issues have far greater number of causes and therefore do make it harder to access. That said, given that all action, public or private, is made in an environment of uncertainty, I do think that the market allows for a greater level of experimentation that reduces that uncertainty in a more timely basis. As Veronique touched upon, even if we did know the right solution ahead of time, which in my opinion is a big if, there's a whole bunch of different incentives that government actors face that might mean they might not even pursue the right incentive. For instance, as mentioned, compensation of government employees is rarely tied to performance. One doesn't get paid more for success, nor does one get punished for failure. Equally important is the fact that few government employees suffer in the face of failure. You could look at the area that I work in, financial regulation. I think it's beyond question that various bank regulators failed to do their jobs during the financial crisis. I'd go as far as instance to say there was probably no bigger regulatory failure than at the New York Federal Reserve Bank, but its president at that time, Tim Geithner, rather than being punished, was given a promotion for his performance. Again, I'd be the first to say that the private sector has more than its share of problems, but it's hard to think of any firm or industry that has the Federal Government's track record of rewarding failure. I need not go into remind members of the political considerations that often come in mind. Veronique touched upon those. You certainly are very aware of those. You deal with those every day. So I would just skip past those. I will say one of the problems often that we see in government is conflicting objectives. In general, private businesses have a clear set, measurable objectives, In contrast, government programs often result in attempts to make numerous parties happy with the outcome that no party ends up being happy. And while numerous objectives might seem like a benefit, I think it leaves government programs without a clear mandate and makes those programs less accountable to both Congress and to the public. I would say that one of the contrasts between, as the ranking member mentioned, something like Social Security and the current health care is Social Security has a fairly clear objective: to raise elderly people out of poverty. You can measure that, you can determine it, you can see whether it's working or not. When you have programs that have multiple objectives, it's far harder to figure out whether those objectives are being met or not. Let me end with saying, spend my last few seconds talking about some of my examples from banking regulation, which is my area of expertise, not health care. But I do think we need to worry about any type of insurance program where you provide a government guarantee. Are you minimizing the incentive of parties to make responsible choices? We call this moral hazard in the economics literature. But certainly bailing out banks encourages to make them bad decisions. You keep the same banks around. For instance, I'm sad to say that I don't think this is the last time we'll bail out Citibank. We'll probably bail them out a few more times because we continue to keep them around. And so, again, it's important to keep in mind that failure has to be an important component of the learning process. And just like in the private sector, you need to let firms that don't actually do a very good job go away. You need to let programs that don't do a very good job in the government sector go away so that we can focus on those programs that actually do a good job. Thank you.
Thank you. Dr. Thomas.
Chairman, as a ranking member.
We can't quite hear. If you could pull the mic a little closer. Or maybe turn it on.
I'm sorry.
Thank you.
Thank you for the opportunity to testify today regarding the past accomplishments and future potential of Federal intervention in health care. Chairman Issa, during your opening remarks, you said that health care has always been in the private sector and should be. I would respectfully disagree. Health care is one of the most heavily subsidized by government areas of the economy. And if we want to look at a time when health care was still largely in the private sector, we would need to go back to pre-1935. And it is a disturbing picture. Critics of Federal intervention in health care, including my fellow panelists, see intervention as interference, and they see the healthcare industry as a group of private actors, health professionals, hospitals, insurance companies, drug manufacturers, and these private actors would, according to them, if left to their own unregulated devices, do a far better job of providing the American people with broad access to quality health care. Let the market do its work, they say. But these criticisms rely on sharp distinctions between the public and private sector, and they misapply the same basic economic principles to all types of markets, whether the product is houses, handbags, or heart surgery. And I can only notice that each of my panelists are economists, and no one has really talked about how the healthcare market operates specifically, so I will try to do that. Of all the industries that make up the American economy, healthcare most defies the classic model of the private market. Physicians are the quintessential small business owners, and they have traditionally fiercely defended fee-for-service practice as the best system for guarding their patients' health. Yet without publicly funded medical education, research, service delivery systems, and other government-sponsored aspects of medical care, the medical profession would still be the small and struggling band of individualists who began the 20th century with little scientific understanding of how disease spread, much less how to cure it. I think one of the best examples of the dollar-for-dollar value of government investments in medical research were the wartime trials of anti-malarial drugs and penicillin. Penicillin was brought to you by the Federal government, essentially. And I should be very specific to say that the Federal government has not interfered with the private market so much as it has coordinated many public and private actors. So in the development of synthetic anti-malarial drugs that were very important for protecting the lives of U.S. military personnel, the malaria research program proved to be the largest biomedical undertaking to date at that time, and it also became the model for post-war scientific medical research that both private and government research agencies adopted after the war. And that model marshaled the resources of academia, government, and private industry together to produce things like cortisone and a variety of other drugs that we now take for granted and many of us use on a regular basis. So from 1942 to 46, the Office for the Survey of Anti-Malarial Drugs conducted tests on birds and yielded precise pharmacological and toxicological data on 14,000 drugs, roughly 10 a day for 4 years. And the private sector at that time simply was not capable of coordinating such a massive effort. And the survey decisively identified a drug called chloroquine as the drug of choice against malaria. So with my remaining time, the NIH, I think, is certainly one of the most successful examples of federal sponsorship of medicine. But Medicare and Medicaid now function as much to preserve the financial status of middle-class Americans as to enable the poor to purchase health care. And so really, those programs have operated to support the private market in health care as much as to undermine it. And I will conclude with that.
Thank you. I couldn't disagree with you more, Doctor. First of all, I wasn't talking about NIH. It's a small part of the budget compared to the $1 trillion plus that Medicare and Medicaid consume. The ranking member in his opening statement talked about the buy-in rate of Social Security and Medicare. With all due respect, the buy-in rate is mandated by law, and the people who are not in it are, in fact, State employees and city employees who have the good fortune to be out of the system in most cases to their benefit. I'm from California, which is the largest area of an alternative to the Social Security system, one in which the returns are 3 to 4 times greater than what Social Security does, which means for the same amount of dollars in, California State employees, city, county that participate receive far better benefits. But we are not here to talk about Social Security or the NIH. What we are here, I believe, is to figure out some questions that Dr. Winston, and Dr. Winston, Brookings is not a right-wing conservative bastion, is it? Not a trick question.
No.
Okay.
It is not anything to the best of my knowledge.
Well, usually when we look for people on the left, we often look to Brookings. When we look for people on the right, Mercatus, Cato, and so on, often come in. We tried to have a balance here. You said some very important things, and I'm going to use my time specifically on areas that are more liberal for a moment. You mentioned monopolies, free rider, market distortions. Those are all good points, and I think you made some points. And the Affordable Care Act, although I didn't vote for it, does recognize that the market is dysfunctional. But, Dr. Ruge, CMS underpays the prevailing rate, the cost of health care, don't they? So isn't Medicare and Medicaid, administered by CMS, already distorting the market by taking private sector doctors and hospitals and underpaying compared to what the private sector has been paying and cost-shifting then to private sector by statute?
I mean, this is a very good question. I'm not a healthcare expert, but one of the things that we know about government intervention is that it often distorts pretty widely the market it operates in. And as Dr. Thomas has rightly mentioned, the healthcare market has been highly subsidized and government has intervened quite widely. So yes, of course, we can expect that provider would be expected to provide a service at a lower rate than they would otherwise, which hence creates problems, and also force people to pay at a higher price than they could otherwise.
Dr. Calabria, similar question. The fact is that Federal intervention, over $1 trillion worth of money taken involuntarily by American workers that are spent on Medicare, Medicaid, dual eligible, the poor, retirees, and so on, it's over $1 trillion. Is there any case to be made that this, not that it hasn't, the money hasn't done good because people do have health care, but is there any case to be made that it's driven down the cost of delivery to the American people broadly?
See, I think this is something we fundamentally see across a variety of areas, whether it's housing, whether it's education, whether it's health care. If you take something, and again, I'm going to apologize for making members think about their Econ 101 classes, but if you think about something where the supply is relatively fixed, if you give people more money to spend on that, you will largely run up prices. You have to make sure that you're actually doing something that increases supply in the process. And for the most part, health care, like education, like housing, is relatively inelastic. That is, supply does not increase a lot in the interim. So we do need to make sure that it isn't simply captured by providers, but it actually flows through to the ultimate beneficiaries.
One of the areas that I want to bring out today that is going on today, and it's a little off topic, but I think it's appropriate. CMS is reimbursing hospitals at a rate higher than clinics or doctors' offices. And Dr. Thomas, you talked about this rugged individual doctor. I haven't met them, so they must have been before my time, because doctors, in fact, have joined hospitals, and even when they have clinic practices, they're being bought out by hospitals because CMS has made a decision that the same procedure, they will pay 2 to 3 times more if it's done in a hospital, even if not clinically necessary, than if it's done in a clinic or a doctor's office. Is there any question in your mind, not that Affordable Care Act should be scrapped or not scrapped, any of that, is there any question in your mind that we need serious reform in how we deliver medicine so that the patient gets the best value?
Yes, and I agree that we do need reform, but leaving the market to act supposedly independently is not the way to achieve that.
Right, and no one here is suggesting, and I'll close with this, Mr. Ranking Member, no one's suggesting for a moment that we take government out of health care. But the fact is that, and I was with former member Jim Marshall, a dear friend of mine, today, and we were talking about the fact that we've taken the consumer out of the process, and nothing in the Affordable Care Act puts the consumer back into it. If anything, health savings accounts and other areas in which the consumer was making decisions about best value have been taken away. So as much as we can rail for or against the Affordable Care Act, today is one of many hearings that I believe this committee will have on both how do we get good product for the Federal Government, like a website if it's determined to be there, but also how do we deal with the fact that since Medicare enactment, what we've done is we've inordinately driven up the cost of health care, while cost shifting from the government whenever possible to the private sector. It's not sustainable as the government becomes a bigger and bigger buyer. And I think, Mr. Ranking Member, with the Affordable Care Act, we're going to see that, which is we're telling insurance companies what is the cost, and we can't tell them to work for less, so when they give us the cost, it's higher. And I think it's the first time, unlike Medicare, where we define what we'll pay, it's the first time that we're dealing with the market force and finding out that we haven't driven down cost, and that's something that your constituents and my constituents demand that we figure out how to do. And with that, Mr. Ranking Member Elijah, I recognize you.
Thank you very much, Mr. Chairman. Mr. Chairman, I too want a good product for the Federal Government, and I do believe in effectiveness and efficiency. And I also want to make sure that every single American has health care and that we save lives. And so I want to thank our hearing witnesses for being here today. And Dr. Thomas, the basic idea seems to be in this hearing that the government is bad and the private sector is good. The government should not intervene. It should not try to help people, and it should not distort market forces. I certainly understand the logic behind free market principles, but I think we need to recognize that private corporations are not going to necessarily look out for the poorest, the sickest, and the least fortunate among us. We've seen people thrown off of their insurance policies over and over again. We see the pre-existing condition situation where a woman had minor ailments in the past, and next thing you know, she didn't have insurance because she didn't even know that it was a pre-existing condition. So, Dr. Thomas, I want to ask you, as a historian, to take us back and describe for us what it was like for our nation's seniors 100 years ago, before Social Security, before Medicare, before they had the social safety net that they have today. What was it like for poor, elderly Americans heading into their final years when they were unable to work or to rely on a family or friends?
Well, before Social Security and before Medicare and Medicaid, older Americans were the single most impoverished demographic group in American society. And one of the problems with healthcare markets is that it's not profitable to provide many types of healthcare that are most needed. So care for long-term chronic disability, such as that caused by tuberculosis or cancer or many other diseases that afflict us in old age, is very expensive to provide. And so that has traditionally been provided in many cases by either nonprofit charitable organizations or by government hospitals. And in those days, many poor people would end up in poorhouses, and there were no separate health facilities to even care for them.
Is it safe to say that some of them died early?
Absolutely, yes.
And so they went to, so where did they go for health care services if they had no insurance?
Well, if they were lucky enough to belong to a fraternal order, they might go to their fellow members for help. But the resources there were so small, and in many, especially in the rural South and in poorer parts of the country, and even in the poor areas of northern cities, the resources were simply not available, either individually or collectively, to pay for adequate medical care, and certainly not for preventive care. And I think one thing we haven't really talked about is the cost of not preventing disease is much greater than the cost of preventing it.
Ron Paul stated during a debate in 2012 that when he started medicine, and he'll quote, he said, there was no Medicare or Medicaid and nobody was out in the streets. I don't know how old he is, but do you agree with that assessment?
He's old.
I do not. In fact, there's been a very lively, in the 30s and 40s, people were riding the rails. Many people were, in fact, homeless during the Depression. I don't know how old he is, but certainly there were people on the streets at that time as well.
There's a New York Times article this morning that talks about 39% of the bank tellers in New York are getting some type of public assistance. And, of course, that probably means a lot of them don't have insurance. They need some assistance. What about that type of population? And this is in New York now.
Right. Well, they can go to city, state, and federally funded health clinics. They can end up in their emergency rooms of their local hospitals, who are required by law to care for them. And in some cases, they may get inadequate care or get care too late. Which can end up being even more costly in the long run.
And that doesn't
or they
necessarily
may die.
and that doesn't necessarily include the follow-up.
Correct.
Right. They may get care right there, but then the question is what follow-up is there? Is that right?
That's right. And if the services are not coordinated and that's a function that government agencies often have. If the services are not coordinated, then it may be very difficult for individuals to navigate through the system and get care.
Just last question. You know, Dr. Thomas, the report in the Washington Post cited a report issued in 1959 by the U.S. Department of Health and Education and Welfare, finding that the elderly face disproportionate risks of illnesses, yet had less ability to afford medical care, mostly because of fixed incomes. It also cited a report issued in 1963 by Social Security Administration, which concluded, and I quote, "Many aged persons never recover from economic effects of a single hospital episode. Unfortunately, the heaviest burden is likely to fall on those with the least resources, and even for the insured, there is no present guarantee against dependency in old age caused by catastrophic medical expenses." Do you agree with that?
I do, and a major problem with the healthcare market is the people who are most likely to be able to participate in the private healthcare market are the least likely to need extensive and very expensive care. And so if we do not broker a system where everyone is participating and everyone is covered, then there will be large populations that are not covered and that create major needs for care.
Thank you, Mr. Chairman.
Thank you. I now ask unanimous consent that the pages from Wikipedia on Alexander Fleming be placed in the record. Without objection. Dr. Thomas, you know who Dr. Fleming was?
Of course I do.
And so March 7th, 1929 is the date of the invention and naming of penicillin in Scotland? Okay. I just want to make sure it was World War I that caused it to be invented. It was World War II that it was widely used in, had very little to do with the U.S. federal government, except that we were a recipient of Scottish invention.
Mr. Chairman,
I'm sorry.
would you yield for a unanimous consent request?
Of course.
I thank the Chair. While we're putting things to the record, I'd ask unanimous consent that an article from Washington Monthly called "The Best Care Anywhere" by Philip Longman be entered into.
Without objection,
I
so
thank
ordered.
the Chair.
Dr. Thomas, I put this in, but I went beyond it. Is there something you wanted to say? I didn't want to cut you off.
Just that we may have had penicillin before World War II, but we did not know in what dosage to use it or how to effectively treat disease with it until we conducted clinical trials during World War II that were coordinated by the federal government.
By the
That is what I meant.
Department of War, yes. We now go to the distinguished gentleman from Florida, Mr. Mica.
Thank you, Mr. Distinguished Chairman. Good to be with you this morning. Thanks for highlighting some of the issues that we face with the size and scope and reach of government. Probably some fundamental questions ever since the founding of the Republic, get away from king's distant rule, taxation without representation, and then the size and scope of government and their interference in the colony's affairs, shifting to the creation of our current government. Founding fathers were always skeptical of government, and again, probably for good reason. The longer I stay here, the longer I'm convinced the government could screw up a two-car funeral, and if given the opportunity, it often does. Big government programs, I saw some of your comments, Dr. Winston, sometimes are adopted because a need isn't, a social need or public need is not met, or the private sector cannot meet that need. In looking at this whole mess, wouldn't it have been possible to, for example, I think there's pretty wide consensus we need to do something about pre-existing conditions, about people who were in a lower economic scale, maybe not poverty scale, but couldn't afford health care. But these were some of the deficits that brought about the government and people stepping in saying that government had to take a bigger role. But honestly, the question I would pose is, wouldn't it have been possible to take and tweak some existing things to establish a rule that these plans, and then let the private sector put the plans out there, rather than creating the exchange, the bureaucracy? I remember they came to me, and I was chairman of transportation. We oversee public buildings. They came and said, we just came to tell you we need a building in Washington that will house 5,000 people. That's the administrative people required under the, I'm not talking about enforcement people, just the, I was kind of stunned, and they said, well, the bill mandates this. We just can do it. All we have to do is tell you. And then they came back later, and I think they needed a building for 7,000. But couldn't it have been done by changing some of the requirements and then letting competition and the private sector existing mechanism rather than big government take it over? Dr. Winston, then others?
Yeah. I mean, I'm not an expert in health care, but to be honest, I asked the same question. I mean, my thinking about this is we already have an existing insurance program in the government that's quite a large one, and from my understanding, a successful one.
We have Medicare, we have Medicaid.
Exactly.
Medicaid in particular, might be a vehicle. But we could have also mandated that insurance plans cover some of these, or they
or allow them into the government's plan. I mean, that was my sense. I mean, I think what we're grappling with is, again, what really would be the, quote, lowest cost solution?
Exactly.
To the extent we want to achieve this goal, how could we do it at least cost? Now, my understanding from the experts I know is there's no magic bullet. No one has ever told me, look, we all know exactly what would be the least cost solution. I think that's one of the intellectual challenges in dealing with this. But that said, it would have been nice to at least see a set of alternatives, including the one that you're talking about, and one that intuitively to me made sense, and sort of get these head to head and sort of see how we should go forward. Now, maybe that was out there, but through political compromises that didn't work. But I think it would at least be good to separate out the economics and then the politics.
We got something else you wanted to comment? And then
I mean, government intervention always creates distortion. So no matter what it would have done. So the question is, how do you get the government to do exactly that social goal at the least cost without introducing too much distortion? And it is worth noting that one of the goals of the ACA was to provide universal coverage, which, by the way, getting insurance is very different from getting improved health outcome. And when you look at the actual results, it's like actually not everyone is going to get insurance. So right there, when you try to measure success and failures, you see that there is a problem in the way the whole thing was designed. And yes, targeting it better could have achieved it. It would have introduced distortions, because it always does, but it would have been probably better and maybe even have achieved the stated goal of the ACA.
Did you want to allow him?
You can go ahead and answer briefly.
Okay, what I'll start out with, we know that the resources have costs, therefore we know that the market's not going to provide anything at zero cost. So the fact that somebody cannot afford something when they have zero income is not a market failure. It's also important to keep in mind that somebody with zero income can't pay taxes, and we don't consider that a government failure. So my point being is that we confuse, in my opinion, a number of programs with thinking that this is some market failure to provide a good, when the problem that we're facing is an issue of poverty. If rich people don't have this problem, then we know it's not a market failure. And essentially, I think we'd have a much better functioning government if we gave people in poverty the dignity of, let's cut you a check to make you non-poor, and let's let you make the decisions for what is important in your life for you to spend that money on, rather than us tying assistance to a whole basket of various different goods, of which, of course, the providers grab most of the subsidy anyhow.
Thank you.
I thank you. We now go to the gentlelady from New York, Ms. Maloney.
I want to thank the Chairman and the Ranking Member for holding this important hearing, and all of the panelists for their testimony, many of whom represent distinguished institutions of learning and think tanks. And I would like to quote my own distinguished comedic think tank, the Borowitz Report. Now, Andy Borowitz has pointed out that many or some of my Republican colleagues have criticized President Obama and his team for having the audacity to support one of their own ideas, an idea that came out of the Heritage Foundation. And I would like to quote the conservative Heritage Foundation, which had praise for a plan that it described this way. And this was their report in 2006 on Romney Care. This statement, they said, quote, "The cornerstone for this reform is a personal, responsible, and responsibility principle. The plan establishes a health insurance exchange to enable individuals to purchase health insurance. The plan also focuses on restraining the growth in health care costs by empowering consumers and making health care service and cost information more readily available." End quote. The distinguished report went on to criticize some of my Republican colleagues for plotting to make the Affordable Care Act work, criticizing efforts by President Obama and his team to be flexible, to make adjustments in their plan. Some went on to criticize the President and his team for having a website that was far too slow. Then some turned around and criticized the President's team for having a website that worked too fast. So we have some difficulty in working together, but I do think that you raised some important points in your testimony, Dr. Thomas, and I'd like to quote the area where you talked about how health care, not only the improvement in quality of life and education, but the life expectancy has been improved by 37 years. And some of this was because of public health care and public health care research and standards. And I want to thank you for pointing that out. But I have some further questions on health care. And I'd like to ask you, Dr. Thomas, do you remember how many Americans were without health care insurance before the passage of the Affordable Care Act? How many Americans were it? There were many reports. Do you remember how many Americans did not have health care?
I've always gone with the figure of approximately 40 million.
There's some that say 50.7 million in 2010.
Right.
And I also want to cite a very important study in 2009 by the Harvard School of Public Health. Now, this celebrated study, you may remember it, found that a large number of early deaths were associated with the lack of health insurance. And they further pointed out that 45,000 Americans died yearly, in their report they estimated, because they did not have health insurance. Now, do you believe this report, Dr. Thomas, that came from the Harvard School of Public Health?
Yes, I do.
You do believe that that many people were dying. And before the passage of the Affordable Health Care Act, do you recall the percentage of people without health care by states? There were a lot of reports that showed the percentage of people who did not have health care, and it varied dramatically from 4% to 24%. The 24% was the state of Texas, and the 4%, guess what state it was? What state was it that had the highest number of people with health insurance? Only 4% of their population did not have it.
I'm guessing Connecticut, but I
No, it was Massachusetts.
Okay, right.
Because of Romney Care.
Yes, of course, yes.
Romney Care. And I did my own survey. I called everyone I know in Massachusetts. They were very happy with their health care coverage. And do you understand why there was a difference between the 4% and the 24%? What was the difference?
Because there was Romney Care in Massachusetts.
Right, yeah, Romney Care, which President Obama gives full credit to the distinguished governor, former governor, for his work in supplying health care to the vast majority of the people who live there. And are you also aware that in the 3 years since 2010, the real per capita annual growth rate of national health expenditure has been just 1.3%? And this responds to the concerns that I think are very legitimate of the Chairman to contain costs. We all agree the costs were out of control, and the historic average growth rate was 4.5%. But now, because of the Affordable Care Act, we are at 1.3% growth in the cost of medical care. So I'd like to ask any of the panelists, are you able to point to any prior 3-year period that saw a lower growth rate in our national health care expenditures ever in history?
The gentlelady's time has expired, but please answer.
So actually, the growth in the cost of healthcare has been going down since 2003, and in fact, it has stopped to decline since 2009. So in some ways, you could actually say that maybe the ACA has actually paused that decline in the cost. And in fact, CMS has put out a report, which actually one of my colleagues, a trustee for Social Security and Medicare, Charles
Reclaiming my time, if you could get your response in writing, because I think it's very important, and it's absolutely different from the report that I have seen on the per capita growth rate that showed a 4.5 annual growth in expenditures.
Without
I think this is an important point.
Without
We should
objection,
get
that
this on the
material can
record.
be placed in the record.
Absolutely.
Thank you. We now go to the gentleman from South Carolina.
And may I also place in the record my research on this, and from the National Institute of Health on the growth rate during those periods.
Anything from the National Institute of Health will be welcome, without objection.
Thank you.
Mr. Gowdy.
Thank you, Mr. Chairman. The debate over the role of government in our republic is a fascinating one and probably outside the boundaries of a 5-minute Q&A. What is not debatable is if government is going to enter into something, we have a legitimate expectation that they do so competently and in a trustworthy fashion. So, Dr. Thomas, let me start with you. What do you think the largest avoidable mistake was with respect to the rollout of the website? The largest avoidable mistake.
I am not qualified to speak to that. I am not knowledgeable about the technological aspects of the website.
Neither are the people who drafted who designed the website, apparently. You have no thoughts on what the largest avoidable mistake was with respect to the website.
I do not.
Dr. Calabria?
I would preface with the saying that I'm not an IT expert. I'm not an expert on the website, but so I certainly would say the sense you had to have it running by a certain date rather than having made sure it was ready before, I certainly think is a mistake, but I would emphasize what Dr. Thomas said, not expert on the website.
Well, let me ask you this then. If you're not an expert on the website, it strikes me that if there's a security issue with Amazon or eBay, the consumer has recourse. There are consequences for that. What are the consequences if there are security issues with a government website? I mean, you can argue that there would be electoral consequences, but we had a several-hour hearing, and I still can't tell you who was responsible for the website. I can tell you it's not the President, it's not Kathleen Sebelius, it's not any of the people that you would think would be responsible for this train wreck. So what does a consumer do when they are let down by a government website?
And I think that's an important point, and both Veronique and myself talked about the role of incentives here, which is, I mean, A, there's often not clear chains of authority. I mean, the buck should stop somewhere with something, and there's never any, penalty. There's never any punishment. Certainly not the website. I mean, alone, we've all heard the stories of NSA spying and going through, what we're all looking at and on the web, but I haven't yet heard of any NSA employees being disciplined for that.
I got one even worse than that. How about the GSA? Do you remember the picture of the gentleman with the glass of wine in the hot tub?
Oh, yeah.
Do you know what consequences came from that?
I believe they rehired him, and of course I'll also say, as somebody who follows financial services, you have probably heard of the very large number of SEC employees who spent the financial crisis looking at porn sites on their office. None of them were fired. So again, where is the accountability? Where does the buck stop? Is an important part of this question.
Dr. Winston?
I mentioned in my testimony that story that I read about an IT supplier who offered to build this website at no cost. I can't remember exactly now the name of the firm, but they had a lot of experience doing it. They were, and I'm sure we could find that out. But they were told they couldn't do it because of regulatory constraints, and then the government went out and hired another firm. You know, at the very least, one could have brought them on as a technical consultant or somebody who, you know, could provide guidance, because they certainly were confident enough and experienced enough to do it. So I think clearly an avoidable mistake was just the lack of ability to bring in the highest level of technical advice and competence, which apparently, you know, may have been able to prevent some of the problems that occurred.
Well, it just strikes me that you can debate the role of government, but if government's going to do something, you really should not debate whether it ought to be done competently and in a trustworthy fashion. And there are no consequences, or if there are, I haven't seen them today. With that, I would yield to the Chairman.
I thank you for yielding. I just want to get two things in the record quickly. One of them is, because there was the doubling of life expectancy, I just want to get into the record. In 1960, we spent 5% of GDP on health care, and we had a 69.7 combined life expectancy age. In 2006, we spent 16%, a more than threefold increase in the percentage of our growing GDP we had. We became very wealthy during this period, but we exceeded it by triple, and we raised ourselves by 8 years to 77.7. Mr. Calabria, Dr. Calabria, quite frankly, isn't that what we should be talking about, is how we spend more than 3 times the growing wealth of our nation on health care? And yes, we're getting an increase in life expectancy, but certainly not proportional, and not when you look at our competitiveness around the world, where countries like Canada to our north spend a third to a half less than we do.
I would very much agree. You could certainly say that we're spending a lot of money on these things, but what are we getting? You know, we're getting a bang for our buck, and we could do a far better job of that and trying to get more efficiencies out of that, which I think gets back particularly to Congressman Mica's point about having some consumer choice in this, you know, to me is an incredibly important part of it.
Dr. Thomas, my colleague said something, and I'm taking something because he said it, and he's rightfully so. He said universal health care. The debate that we are having today is on something that's not universal. It's an extension of Medicaid, effectively. It's a vast expansion of Medicaid, both in literally who gets it and in this subsidy that is effectively a backdoor Medicaid for the working, less wealthy, up to over $60,000. From a standpoint of your view of the good it's doing, it is predicted we will get to 20% to 21% of GDP as a result of the Affordable Care Act in total health care spending. Would you sit here today and say that our goal should be to deliver life expectancy beyond 78 years and do it for less than 21% of GDP?
I would respond to that by saying that our health care spending, we are living longer than ever before, and much of our health care spending is to deal with the chronic diseases of old age that we used to not have to deal with because people were dying earlier.
Okay, well, my time has expired, so does anyone want to answer the question, which is, should we have a goal to live long, live well, and do it at a rate below 21% and growing, or likely to be 21% and growing percentage of GDP, when we're competing against nations that have 9% or less and have life expectancy as long as ours? Hearing none, I will recognize that my time has expired.
Mr. Chairman, could I correct one thing very, very briefly that my friend from Virginia told me that there were consequences that arose from a hearing that we had with respect to GS8. If my friend from Virginia tells me that, I believe him, and I will take it upon myself, Mr. Chairman, to find out the full panoply of the consequences and report back to you and to my friend from Virginia.
I thank you, and I don't think there's anyone here that would fail to think there should be consequences in the case of GSA. And with that, we go to the gentlelady and my friend from the District of Columbia, Ms. Norton.
Thank you, Mr. Chairman. And just to try to respond to your question about the correlation between the increase in life expectancy and what we spend, sure, it's going to go down, because we've been spending, and I think Dr. Thomas gave one answer, but you know, the Affordable Health Care Act is going to help there, because we've been spending this money on sending people up until now to the emergency room. We've been spending almost no money on preventative care. We have been spending disproportionate amounts of money on the very last years of life when people are about to die anyway. You know, you'd have to look at a lot of factors. But I do want to thank, yeah, but if you don't take my time
I'll stop the clock. Are you saying that there's something in the Affordable Care Act that's actually going to drive down that
I am saying,
trend?
for example, that the subsidies, which are part of the Affordable Health Care Act, means that people are going to get their own doctors, that they're going to have preventative care, that you won't get to the point where the disease is costly. You have to have the most expensive procedure. You have to have your leg taken off. I'm saying that those things will, in time, show up. They're not going to show up in the first few weeks of the rollout. And I do want to thank what very distinguished panel. One of them is one of my own constituents. Welcome, Mr. Calabria. But I want to thank all of you and for your testimony. I do note for the record that only Dr. Thomas is an expert in health care, and I think that must have been deliberate, because we're talking about the rollout of health care, and that's without casting any aspersion on the very distinguished witnesses we have here. But what really troubles me, Mr. Chairman—
Would the gentlelady accept a friendly introduction?
Certainly.
Dr. Thomas, according to our information, is a historian and communications associate at Johns Hopkins. We were unaware. It is the School of Public Health, so it's history of health, but I may be wrong. Perhaps she could tell us what her expertise is in health, because everyone today is a Ph.D. None of these are medical doctors.
She's an expert on health care, Mr. Chairman, and if she's not, let her tell us.
I spent 4 years doing a postdoctoral fellowship in the history of medicine, largely concentrating on 20th century health policy and public health at the Institute of the History of Medicine at Johns Hopkins University.
I was simply drawing the contrast between some background in health care, and I did so even though I respect all three of the other witnesses. Mr. Chairman, I hope that wasn't taken from my time. But I do want to say that this is an amazing hearing, that the government of the people, by the people, and for the people should not provide health care for the people is essentially the theme of this hearing. It's a fundamentally anti-American message. Fortunately, it is false, and I think the Chairman, with his rollout of the many ways in which the government has produced for the people, lays that to rest. The Affordable Health Care Act is not a government program, not even single payer. So I don't even understand the concept here. This is a Republican idea which outsources to the private sector. This is why the insurers brought into the program. That's why they're so anxious that this website get up and get right. Yes, they're getting subsidies, but that is to save the American people money. Nobody's just throwing money at people. Mr. Chairman talked about D.C. HealthLink. Yes, there are errors there, but it was cited as one of the 4 successful rollouts throughout the United States. And I want to cite it because it's an example of why this is not a government program. You go on D.C. HealthLink, 267 options. And when they insisted that on D.C. HealthLink they would put the cost up front out so anybody could see it, they drove competition, and others came in and lowered their prices. This is a quintessentially private sector approach. The government's only role is to say, we're not even refereeing it. We're putting up a website. That's why we think that website has got to be gotten right. Chairman talked about winners and losers. You know, when you've got 267 or whatever the number is in your district, nobody's picking anything except the people who go on that website. Mr. Calabria talked about market feedback. I just cited to you, Mr. Calabria, what the market feedback was when when competitors saw 267 prices on the link. They never could have seen it otherwise. The individual never could have gotten that information if it had not been for DC HealthLink. My staff went on there and report, for example, several of them have reported to me that they've saved $100 already looking on their site with comparable health care, $100 per month. Dr. Winston talked about programs in the public sector can't, like ACA, do not necessarily drive down costs, and he may be right. Of course, I've cited an example where, precisely because the government put this website out, costs are being driven down. One thing that ACA does not have is a mechanism, a government mechanism for driving down costs. They're depending upon this competition to do so. I want to ask Dr. Thomas about since what's supposed to have spurred this was the rollout, about the Medicare rollout. Now, we would have done Part D in a different way. The last thing we did, though, when it finally happened, we certainly didn't say, well, just wipe it off the board. We didn't try to repeal it. Do you recall public and, for that matter, political sentiment at the time of the Medicare D rollout, whether there were large problems?
The gentlelady's time has expired.
But my time was taken up, Mr. Chairman,
no,
by you, among others.
We stopped the clock.
You don't even want to let her answer the question?
No, I was saying your time has expired, but the gentlelady certainly can answer.
At the time of the Part D rollout in 2005 and 2006, there was great concern about how complex the instructions were for enrollment, and people were very concerned that their existing drug coverage would end and that they would not be picked up by the new law. And there were great difficulties in the initial implementation of the law that have since been fixed, and we now, I think, are in bipartisan agreement that Medicare Part D is working and is a good program.
Thank you, Mr. Chairman.
Thank you. The gentleman from Tennessee, Mr. Duncan.
Well, thank you, Mr. Chairman. I remember during my first term in Congress in 1989, I went to a conference put on by the American Medical Association, and the man who was then the president of the AMA was laughing in a presentation that he made about the fact that, as the ranking member mentioned, that the AMA had opposed Medicare because he said that he knew at the time it was started that the doctors would get their part, and they certainly have.
Yes.
Many doctors have gotten wealthy off of it. And I remember reading last year, I think it was an Associated Press article, that 6 of the 10 wealthiest counties in this country are suburban counties to Washington, D.C. And what I'm getting at is that, as Dr. DeBruge has mentioned, all these federal programs, they have wonderful motherhood and apple pie titles, and they have good goals, but they end up benefiting primarily government contractors, large corporations and government employees. But you mentioned Goldman Sachs and some other companies, and I noticed that CGI. The chairman mentioned that we've spent $640 million so far on the website. The Canadian company whose American subsidiary got the bulk of the money on the website, one of the top officers is a close friend to the president's family. And all of these government contracts, when you go beneath the surface and you find out what's behind it, almost all these big Federal contracts are some sort of sweetheart or insider deals. I mean, I read several years ago about the revolving door at the Pentagon, because they hire all the retired admirals and generals, and then the defense contractors do. And the same thing is going to happen, I'm afraid, with Obamacare. It's going to end up benefiting some extremely big companies. I read just this morning an article that some of the health insurance companies are now working with the White House to try to implement the program, because they see huge profits ahead. And I think back to the mid-90s when I went to a reception in Tennessee, and the doctor who delivered me came and brought my records, and I asked him how much he charged back then. He said he charged $60 for 9 months of care and the delivery if they could afford it. Medical care used to be cheap and affordable, and doctors even made house calls, and then the Federal government got into it. The same thing has happened. It shocks students at the University of Tennessee when I tell them that it was $90 a quarter when I went there, $270 a year, and then they started the Federal Student Loan Program, and every year since, and until that program started, college tuition and fees went up at just the rate of inflation. Then when the Federal government got into it, every year since then, it's gone up 3 or 4 or 5 times the rate of inflation. And it just seems that everything the Federal government subsidizes, the costs just explode. And we talk now, already we're hearing that Obamacare is going to cost 3 or 4 times more than when it was passed. And I remember reading years ago that Medicare, it was predicted, was going to cost $25 billion after the or it was going to cost $12 billion after the first 25 years. Instead, it cost almost 10 times that much, and now it costs 4 times more than that. And so all these Federal medical programs have been lowballed on the front end. And what I don't understand is how we're going to add many millions of people who were previously uninsured, and now millions more are receiving notices saying that their premiums are going out the window so much that they're not going to be able to afford those premiums, so we're going to add all those millions. I mean, these costs, it seems to me, are inevitably going to explode. Dr. DeRuggi, what do you say about that?
I mean, I agree with you. I mean, a lot of these programs, independently of the benefits, the social benefit that we assign them, are unsustainable, whether we like them or not. Medicare, Social Security, Medicaid, these are programs that are extremely expensive. And then you add on top of it the ACA, and you have we already have a big debt problem, but it's going to explode. And I wanted to add something about what you said. I mean, yes, the private insurance industry was extremely supportive because they were going to benefit immensely for it. When you have a law that mandates that everyone buys insurance, that means millions more more customers for the insurance industry. And I will bear to also say that in this instance, because of the way the law was drafted, I mean, the law did pick winner and losers, since because of the requirement by Obamacare, it meant that younger and healthier Americans were going to have to face much higher premiums.
The gentleman's time has expired. Dr. Winston, if you need to answer.
I just want to add one point just to round out what you were saying. I think it's important to keep in mind that a large source of the increase in medical expenditures is due to technological change and innovation. Obviously, we're not getting the same products that we once got.
Well, the problem
is that's a good thing, but I think the challenge and that's coming from the private sector to a large extent. The challenge for government is, how is it that they intervene in ways that spur technological change and innovation without excessive increases in costs, as opposed to impeding technological change and innovation.
Well,
that's really what we need to do.
I'll close just by saying that we're having great difficulty funding the programs that we already have.
I thank the gentleman. We now go to the gentleman from Massachusetts, Mr. Kearney.
Thank you, Mr. Chairman. So, Dr. Calabria, I just want to note that we're here for a hearing on the rollout of healthcare government. Your own testimony says, and I quote, "I am not an expert on healthcare." Is that right?
That's correct.
Okay. And in your statement, you also say, and I quote, "Doing nothing should always be an option, or rather leaving the problem to be solved by the voluntary private sector." Close quote. Is that accurate as well?
Absolutely. You can always make something worse.
Thank you. Dr. DeRugby, in your written testimony, you focus mostly on the Department of Energy's loan guarantee program. And then you say, and I quote, "Government solutions are not only unlikely to solve most of our problems, they often make problems worse." Is that fair?
It is fair.
Okay. Dr. Winston, you are talked mostly about transportation and infrastructure programs. Let me quote from your testimony, "I am much less familiar with empirical assessments of government services and programs to pursue social goals." Close quote. Is that an accurate quote?
Yes.
Thank you. So, Dr. Thomas, you actually work in the public health field. You have the background that you just stated on that. So I want to focus a little bit on you and talk about this concept that the free market always works better. Before Horace Mann, how were the private sector doing on educating most students in this country?
In some parts of the country, literacy rates were high, but in many, many parts of the country, there was no education available to the vast majority of the population.
And before Social Security and Medicare, what was the poverty rate among seniors?
I do not specifically know, but I know that it was significant and that health costs were a major part of that poverty.
And how did Social Security and Medicare's enactment affect that?
Together, because we need to remember Medicare and Medicaid are parts of the Social Security Act, together those things lifted many, many millions of Americans out of poverty. And I think it's important to add that minority groups who had been hardest hit by poverty rates were also dramatically helped by those programs.
And I would assume that since the recession, the fact that 95% of all economic gains have gone to the top 1% is not what you would think is a great symbol of the private market working effectively for everybody?
No, I would not.
Okay. So the premise of this by the majority seems to be the government's ability to effectively or inability to effectively design, implement, and administer large-scale projects and programs. Let me talk to you a second about the GI Bill. Is it your understanding that the GI Bill has been a success?
Absolutely. My own father went to Georgia Tech on the GI Bill.
And in fact, on November 8th of this year, we had the 1 millionth recipient of the GI Bill that was passed after September 11th, 2001.
Yes.
Sorry. And basically, I would think that the government has been administering that program fairly well, in your opinion?
Yes,
Some $30 billion in new GI Bill benefits have been awarded to Iraq and Afghanistan veterans since 2009. Is that about right?
Yes.
Okay. So you would think that the GI Bill has been worth the effort of the Federal Government in its expenditures?
Yes, and it helped the overall market to work better because it brought so many more skilled people into the workforce.
Now, the intervention of government in 1966, but through Medicare, that saw some problems with the rollout of that program, similar to what we're hearing today?
Very similar.
And in 1937, we can say the same about Social Security, correct? People were all sorts of critics about the program. It was going to cause too much swelling of bureaucracy. It was going to slow the economy.
Correct.
And Part D, Medicare Part D, talked about there being a mod rollout. And the Republicans, in fact, at that point in time, however, were saying, look, it's a mod rollout, but it has glitches. We should work closely with CMS to get the problems resolved on that.
Yes.
All right. And I would protest that if we work closely with the glitches in the Affordable Care Act, we can get those resolved as well. Would you agree?
I agree. I think the Affordable Care Act is very much in the tradition of these other programs that you've mentioned, and that we're going to look back even a year from now and see that the Affordable Care Act is a good investment and is working.
So historically, are you familiar with any program that the Republicans propose during this discussion of the Affordable Care Act that would cover the 40 million Americans that were otherwise uncovered?
I am not.
Are you aware of any proposal that would affordably allow people to stay on their policy until they're 26 if they're not otherwise covered, stay on their parents' policy?
No.
Are you aware of any Republican suggestions of how they would affordably make sure that insurance companies didn't shut off your health insurance with an annual or a lifetime cap on coverage?
No, the insurance companies had done none of this on their own.
And the same is true with pre-existing conditions, is that correct?
Correct.
I yield back. Thank you.
I thank the gentleman. I now ask unanimous consent that 15 letters sent to health insurance companies related to broken promises, and when did they know, excuse me, when did they know that they were going to be canceling individuals under the Affordable Care Act be placed in the record. Without objection, so ordered. We now go to Mr. Meadows, who came back just in the nick of time.
Thank you, Mr. Chairman. Dr. Thomas, I know that my friend and colleague was asking you about Republican proposals, and hopefully this is not something. How many people do they estimate will still be uninsured under ACA? Do you know?
I do not have an exact figure.
Do you have an approximate figure? You're a historian.
Yes.
So you don't know trends?
Well,
so under ACA, how many people will, you were able to quote how many were going to be covered, so I would assume that you would know how many are going to be left uncovered.
I think there will still be approximately 5 to 10% uncovered.
Well, according to estimates, some 30 million people will still be left uninsured, is what the current estimates have. Some 30 million people would still be without insurance, even under ACA.
And may I ask where those estimates are from?
A CBO. And so if you look at the CBO, they're saying almost 30 million people will still not be covered. So this is not a solution that will have everybody covered. So I want to ask, you've gone and you've had a number of options here as we've started to look at history. Can you speak to the fact that we have trends right now where under current Medicaid and Medicare that the reimbursements are not covering the costs? Would you agree with that? To provide those health care coverage. Does Medicaid cover all the cost of actually providing that service? The reimbursement to physicians?
No, it does not.
All right. So does that distort the market?
The rates of
reimbursement.
Well, I can speak from personal experience. When you get an explanation of benefits from a medical visit.
All right. Let me change. Maybe let me change and rephrase the question. Do you ever hear complaints from physicians where they don't want to take new patients because the reimbursement is not adequate to cover their cost? That's an easier question.
Yes. However, in some cases, over time, Medicare has reimbursed at higher rates than private insurance.
Okay, but let's look at Medicaid. I'm in a rural area, and so we get a lot of Medicaid patients. And what I'm finding is a lot of physicians don't want to take Medicaid patients because the reimbursement doesn't even cover their costs, hospitals included. Would you agree with that?
I would, but I would also say that without the Medicaid program, there would be far more people who wouldn't get care at all.
All right. Is there not a federal law that says everyone has to get care?
There's a federal law.
So it's a matter. Is there a federal law? Yes or no?
Care in the emergency room, yes.
Right. So it's a matter of how we get that care to them in terms of the efficiency of that. Because right now there is a law. If I show up, regardless of my ability to pay, at an emergency room, I can get care. Is that correct?
Yes.
That's federal law. So what we're talking about is the efficiency, as Dr. Winston talked about earlier, is what is the most efficient way to deliver that health care. Is that not correct?
Yes.
All right. So in doing that, from a historical perspective, are there major inefficiencies in government delivery of services, whether they be medical or anything else? Are there inefficiencies there?
Certainly.
All right. So has the private sector historically done a more efficient job of providing services, whether they be medical or not? Have they historically done a better job of providing a more efficient delivery, historically speaking? You're under oath.
You're talking about all of the private sector in all parts of the economy?
I'm saying historically speaking. You're talking about trends. Historically speaking, is the private sector a more efficient mode of delivering goods and services, whether they be medical or not? Historically speaking, have they been more efficient? You're a historian.
I don't think I can answer that question because it is so broad.
Okay. Well, my time has expired. I'll yield back. Thank you, Mr. Chairman.
We now go to the gentleman from Virginia, Mr. Connolly.
I thank the Chairman, and I'm delighted to hear my friend from North Carolina's concern about uncovered citizens. Hopefully North Carolina and Virginia will both come to their senses and broaden Medicaid so that those people will have coverage. And by the way, let me follow up on my friend's last question to you, Dr. Thomas. Historically, since World War II, can you give us a single industrialized country where the government has not intervened and provided health care to its citizens?
No, there are none.
There are none. So that efficient private sector somehow just didn't work in any industrialized country. The United States is actually lagging way behind others in the industrialized world in the comprehensiveness of its coverage until the passage of the ACA. Would that be an accurate historical statement?
That is absolutely true.
And you are under oath, as my friend reminded you.
Yes,
Thank
that
you.
is absolutely true.
Dr. DeRuggie, excuse me, I hope I'm pronouncing that correctly.
Yes, fair enough.
You're entitled to your name.
De Rugy. It's fine.
All right, I'm sorry. My friend, the Chairman, characterized Brookings as a left-of-center organization in contradistinction to your center, the Mercatus Center, which he characterized as right-wing, right-of-center. Would you accept that characterization?
No, actually, we're really independent. We
Really
spend
independent.
a great amount of time criticizing both sides of the aisle.
And lots of donors, like the Koch brothers, for example. Is that correct?
We have lots of individual donors.
Including the Koch brothers?
It's like, yes, it's well known.
Yes. You don't come here as a healthcare expert. You come here as an economist. Is that correctly?
That's correct.
And your position is a priori that any government involvement distorts the marketplace.
It does.
It does. So you consider Medicare a distortion?
It does, yes.
Medicaid?
Medicaid. Is,
Veterans Administration?
We may be willing to put up with distortion to
I'm not
achieve some social goals.
Don't jump ahead. I'm asking the question here. So is TRICARE, medical TRICARE, military TRICARE healthcare, a distortion in the marketplace, based on your philosophy?
Government intervention, all government intervention introduced distortions.
And that includes the Veterans Administration healthcare system?
It does.
It does, and I see Dr. Calabria agreeing with you. Does the Center for Disease Control, is that a distortion? It's a big government program, monitors public health.
It does, but again...
Again, ma'am, I'm just trying to see, is it consistent with your philosophy that it represents a distortion? We'll hold off for a minute, normatively, whether it's good or bad.
Government intervention introduced distortions.
And you would include the National Institute of Health in that rubric?
It does.
And the Federal Drug Administration?
It does.
Now,
Certainly.
all right, are some of those things necessary despite their distortive effect?
Yes, absolutely.
Yes.
The government...
Which ones do you think are unnecessary?
So I think there are a lot. For instance, I don't think the government should be involved in education. That's a state and private function. I mean, there's a lot of things.
No, I'm talking about the healthcare system. Would you abolish the CDC and let the private sector monitor public health?
I think there's an important role for the government to try to prevent epidemics, true epidemics. But the CDC does a lot of things that actually it shouldn't be doing. Like
okay. So there are some things you'd go granular and pick what functions you like and what you don't, even though anything you pick is distortive by your definition.
Yes. We've got a government intervention.
Is it excuse me, but because of time, is it your position that absent the government, even in functions you might deign to approve of, the private sector could do it better and should?
Not necessarily.
Not necessarily.
Because, as I said, there are some functions that we may want the government to do, even if it introduces some distortions. And as Dr. Calabria said, the private sector doesn't do everything efficiently.
Right. By the way, there was a debate here earlier about the government setting prices for Medicare. Do you actually know how the process is set for which are recommended and approved procedures? Who does that? Who recommends that to the government? Do you know?
I don't know.
It's actually a committee.
Actually, it is a committee made of doctors.
That's
and I
right.
think I remember a report recently that actually highlighted the fact that a lot of what they were doing was boosting prices in area where the service could be delivered at a lower price.
So that's the private sector doing that.
But the government, this is how one of the ways that the government introduces distortion is like it gives incentive to the private sector to try to get as much as it can from the government.
I'd ask unanimous consent. The gentleman have an additional minute without
I thank
objection.
the Chair. Well, of course, philosophically, Dr. Ruge, there's no end of that. That's a horse that left the barn a long time ago. Gosh, if we want to talk about economic distortions in the government's role, let's talk about agriculture.
I agree.
Let's talk about nuclear. All nuclear power in the United States came from federal research and dollars. Now, is it your contention that this big government distortive effect extends to pharmacological research? Because it's my understanding that by and large, all basic research in the United States, and this is not new, is done by the government. It's the commercialization of that basic research is when the pharmaceutical firms come in, but they do not fund basic research, nor are they going to.
Some of the distortions that the government introduces by actually picking and choosing which area are going to be funded, which area should be researched, while other may not.
If we look, yes, that's true. But the
government has a knowledge problem.
Excuse me, pharmaceutical companies do that too, except their motivation is commercial value as opposed to the health value.
Well, actually,
this is a wonderful discussion, but I've got a feeling it could go back and forth for a very long time.
Mr. Chairman, I want to thank you for extending my time. I just wanted to highlight that I appreciate, I think this is a really important debate because it's a very fundamental one in the United States when people say, why can't we all get along? Because we have fundamental differences philosophically about the role of government. And while I respect Dr. Ruge, and I certainly love George Mason University, which is entirely within my district, I couldn't disagree with her more fundamentally. Just as you pointed out, you disagree with Dr. Thomas, I also disagree with Dr. Ruge and her philosophy. Thank you, Mr. Chairman.
Thank you. If I can enter a colloquy quickly, I actually think that all the panelists have said in one way or the other that government is necessary. They all know it causes market distortion. And they all have differing views at the level of government intervention. It could be that you disagree with some of the levels. I'm sure they disagree with some of the levels I would achieve. By the way, one of my major constituents produces Botox, which was a government-funded orphan drug that if not for the government looking at a very rare disease, probably would not be the blockbuster success it is in other areas. So I think we all know that basic research is important. Hopefully here today we're talking about the 16 to 18 to 20% of GDP. Is there a better way to allocate those resources?
Mr. Chairman, I couldn't agree with you more, and I commend you. I think we've actually put together a panel here that has been very stimulating. It highlights some of our differences, but it also asks some provocative questions that need to be asked. And I thank the Chairman for putting it together.
Thank you. And then we're going to get back to FTARA and real IT reform together.
That's it.
Thank you. We now go to the gentleman from Michigan. Oh, I'm sorry.
I wanted, if I may, to add that it's not always just the government that, quote, distorts the market, that sometimes private actors can also drive up prices. And in healthcare, a very good example of that is competition among private hospitals, private for-profit hospitals for highly expensive and complex medical equipment, that one hospital buys the $1 million piece of equipment and they're the only hospital in town with it until the hospital next door buys it also. And really, there's only enough patients to justify one such purchase. So that's one way that private healthcare drives up prices sometimes.
The allocation of resources in healthcare is so complex that, to a great extent, the theme of today is it so complex that neither the public nor the private sector have been able to do it. I apologize, Dr. Winston, but I've taken too much time of everyone's. The gentleman from Michigan.
Thank you, Mr. Chairman, and thank you for holding an important hearing. The founders of this nation understood exactly what some of our witnesses have all expressed. Government makes decisions poorly because too often politicians and bureaucrats do not have the same incentives that the citizenry has. I certainly don't wish to offend my colleagues here, but our government is inherently made up of those with at least a little hubris. After all, it takes some hubris to believe that you should be the representative of the sovereign people of the United States. In fact, I've even heard of people campaigning for office simply to say that they're a congressman rather than from the hope of protecting people's rights, a hubristic style trumps substance in service of the people. Unfortunately, Mr. Chairman, that hubris in our leaders sometimes gets out of control and leads to disaster. The President's health care reform is the only major reform ever passed by one party over a bipartisan opposition. And boy, Obamacare is certainly turning into a disaster. I thank the witnesses for their enlightening testimony. Dr. DeRugi, did I pronounce that correctly? Thank you. You talk a lot about special interest groups and the lack of incentives for politicians to spend taxpayer money wisely, stemming from the average citizen not really feeling the pain from having the collective money of the nation wasted. Could this come from taxpayers simply not realizing how much money is being spent on what departments in government?
That's one of the reasons. I mean, one of the way the government expands is by concentrating benefit of government intervention and spreading the cost thin and wide. And so that's one of the reasons why we don't always see that cost. We also don't necessarily see the distortions, or even when we feel them, it's hard to track it back to a particular government intervention. What's interesting about the ACA, and I'm going to make a prediction and we'll see whether I'm correct, is even when the website is completed, it is possible that the administration is not going to get the benefit and the hooray that people are going to feel, because actually it is a program that is designed the opposite way, where like the benefits are spread somewhat widely to an audience who may not actually be very vocal about how great it is, while the costs are highly concentrated and visible to some, which will continue to be vocal.
Thank you. Do you think that if every taxpayer received a receipt explaining where their tax money went would be useful in granting politicians here in Washington more incentive to act more wisely? More
transparency certainly would be necessary. For instance, I would be very happy to say which part of my taxes go to farm subsidies.
I couldn't agree with you more. With that, thank you very much. I yield back.
Would the gentleman yield?
Yes.
We've had a lively discussion, and I'm sure we're going to continue to. But, Dr. Winston, in your opening remarks, you really did touch on the fact that, and I think it's something that Dr. Thomas also said, monopoly and monopolistic type behavior, distortions in the market, not just by government, but the inherent distortions that occur in both for-profit and not-for-profit hospitals. I happen to have two not-for-profit hospitals 9 miles apart along it's a state highway, but it's built like an interstate, and I can't get them to put one machine that is not emergency related in one and share. They just don't do it. Isn't that part of the problem, and I'll go to Dr. Winston, maybe back to Dr. Thomas, is that healthcare has built with a system that has very little to do with market forces, meaning that market forces already didn't work well in healthcare before we started funding a system that didn't work well from a standpoint of supply and demand. In other words, cash is not king. The consumer is not educated to make a buying. Prices are not transparent. Cost effectiveness is not easy to discover. Dr. Winston?
Yeah, that's right. I mean, there's, it's not distortions, but it's, in a sense, they're wedges, if you will. It's not a simple market. You go to a store, you buy something. You're going through a doctor. You're going through insurance, so on and so forth. So, these wedges make efficient, smooth operations of this market more difficult.
I'm going to ask a closing question for all of you. If this committee, the Committee of Transparency in Government Spending, if we concentrated our efforts related to the Affordable Care Act on mandating transparency in health care so the consumer knew more and the public knew more, would we be well spent in then driving, through market awareness, better distribution of dollars and thus more efficiency? Any opinion?
Yes.
Certainly think
That's Econ 101, so just go ahead and
certainly transparency would help, but you got to get the incentives right, too.
Yeah, incentives are, I think, the critical thing. Information is one thing, but still people have to have incentives and firms have to be able to enter and so on and so forth.
I know people want to buy the best health care. Hopefully, we can create incentives for them to buy it at the lowest possible price. Thank you. We now go to the gentleman from Illinois, Mr. Davis.
Thank you very much, Mr. Chairman. You know, I believe that a good way to measure the greatness of a society is by how well it treats its young, how well it treats its elderly, and how well it looks after those who have some difficulty handling their affairs effectively themselves. Dr. Thomas, as a historian at Johns Hopkins, I'm certain that you have some insight into the question of whether or not the Federal Government, as I've heard questioned, is able to administer large-scale programs effectively.
Yes.
I've heard comparisons between the Federal or the government and the private sector. And so I'd like to ask you about the Medicare program, which was signed into law by President Johnson in 1965. And, Mr. Chairman, I ask unanimous consent to enter into the record an article that appeared in the Washington Post on May 17th of this year.
Without objection, so ordered. I love the Washington Post.
Yeah, it's a great paper. The article is entitled, "When Medicare Launched, Nobody Had Any Clue Whether It Would Work." Dr. Thomas, I'd like to read an excerpt from this article and then get your response. Here's what it says. Medicare in these days, an incredibly popular program. Americans overwhelmingly oppose cutting it. No politician would consider repealing it. Most think providing health insurance to all Americans over 65 is worth both the trouble and the cost. That was not always true. Back in 1966, as Medicare was just about to launch, nobody knew whether the new program would provide benefits to millions or fail completely. Dr. Thomas, based on this reporting, there was trepidation in 1966 with the rollout of the Medicare program. Is that correct?
It's absolutely correct.
Well, the article describes how the American Medical Association ran ads across the country denouncing the program as the beginning of socialized medicine. And many people who were unfamiliar with the program were suspicious of it. Is that correct?
Certainly.
The article also describes the implementation effort. It says that the government launched Project Medicare Alert, with thousands of Federal workers charged with educating people and helping them enroll in the program. Is that correct?
Yes, they had to go door to door to try to reach people, of course, before the Internet, who might not know about the program and make sure they knew they were eligible.
Means they were serious, right? One of the biggest challenges of that era.
They even asked forest rangers to go out in the rural areas.
Was with hospitals in states that did not want to provide health care services to Black Americans. I know that this has been a focus of some of your research and some of your writing. Can you tell us a little bit about how this problem was addressed?
Yes, I would say that one of the greatest moral failures of the private health system, and unfortunately for a time of the public system as well, was its segregation by race of patients and outright denial of care to many Americans in minority groups, so that death rates, disease rates, draft rejection rates, many measures were dramatically higher among African Americans than among whites. And there is a racial disparity in life expectancy and many other health measures that persist to this day.
And yet we've been able to overcome all of those objections and all of those difficulties where now Medicare is considered a very popular program. Everybody who can get it wants it, and I think it just takes a bit of time. It will take some time with the Affordable Care Act, and ultimately, I think that Americans are going to feel the same way about the Affordable Care Act that we now feel about Medicare.
I do.
And I yield back.
I thank the gentleman. Gentlelady may answer if you were mid-sentence.
Just that it was the combination of the 1964 Civil Rights Act and the Medicaid Act of 1965 that definitively integrated the American healthcare system, and it was much more successful in healthcare, and has produced some very good results.
I thank you. I now ask unanimous consent that the New Yorker article entitled GOP HealthCare.gov Too Fast Now be placed in the record. Without objection, so ordered. We now go to the gentleman from Arizona, Dr. Gosar.
Thank you very, very much. Dr. Thomas, I'm just, as a background, I'm a dentist for 25 years, okay? And this can be very important to kind of keep in track of this. Is Medicare financially sustainable as is?
No.
Is Medicaid financially stable as is?
No.
Is Obamacare financially stable as is?
I can't answer that question.
It's a no. Is Romney Care financially viable as is? No.
I
no.
don't know.
I mean, you're a historian. You better know it. You're very flippant with the statistics, and I'm about details. And Romney Care isn't financially stable. The only reason it's lasted so long is it's from a rich state. That's it. And so, aren't they very close to go to a single payer?
I'm sorry. Is Romney Care close to a single?
Yeah,
payer?
Massachusetts.
Yes.
Yeah, that's what I thought. That's how we keep hinting in this way. I'm looking at three problem solvers here, and that's what's key about this thing is that when you have a problem, you always go to lowest common denominators to figure them out. Wouldn't you agree?
I'm not sure what you mean by lowest denominator.
Well, you figure out all the parts that are part of the problem, you go to the lowest basis, and you come up with core principles and build upon simplicity. Wouldn't you agree?
Sure.
Would you agree, Dr. Ruge? Dr. Winston? Dr. Cleveland? Is that possible, the three of you? Is that actually possible today in the federal government to do that? Quick answer. I mean,
no.
And I want to agree with you because we talked about monopolies, we talked about non-competitive bids, we talked about all sorts of things. Is there a tort reform in this bill, Dr. Ruge?
No.
Is it part of the problem?
I guess part of it.
Dr. Winston? Yes. Dr. Cleaver? Hey, how about you, Dr. Thomas?
It is part of the problem, but politically,
I don't care about politically.
Okay.
Because you know what? It has to be part of the solution here, okay? Number two is, we brought up monopolies. Do you think that we've handled, Dr. Thomas, the monopolies of insurance industries properly in Obamacare? I'll give you a minute to catch that answer. How about you, Dr. Ruge?
Absolutely not.
Actually, the federal government is prohibited from interceding in insurance companies by McCarran-Ferguson, is it not?
Yes.
Dr. Winston? Yeah. So, I mean, do you see a need for actuarial tables? I mean, 1945, I see actuarial tables being a necessity. We didn't have good computers back then, but today, you have an algorithm, your own facts, a computer, you should be able to do it on your own. Don't you think, Dr. Ruge? Dr. Winston?
Yeah, times change.
Yeah, absolutely. Yes. Dr. Cleaver? Yeah. Yes, so, I mean, one of the key principles here is that we got a collusive environment, right? Yes. Oh, is any part of this bill talking about repealing McCarran-Ferguson?
No.
Let me ask you, Dr. Ruge, because my colleague from Virginia asked a question. Government intervention would be great here, because in this aspect, the federal government now intercedes and breaks up the monopoly, sends it back to the state. Would it be, Dr. Ruge?
Yes, it would be.
Dr. Winston.
Yeah, I mean, a quick point, if I could just say, is we're looking to government to correct distortions. There's too much emphasis on the distortions it, quote, creates, but its main job is to correct the distortions. That's the problem we're having.
That's exactly, redirect it. So I'm getting to this. Dr. Kleber, do you want to comment on that?
I would absolutely, agree with that. We need to allow competition, particularly across state lines, in terms of bringing competition in the insurance market.
Wow. I mean, I want to turn the insurance industry free because they're harnessed right now.
Or create a level playing field.
What's that?
Create also a level playing field between employer tax credit and the individual market.
Dr. Thomas, can we treat our way out of this epidemic of healthcare? Can we treat our way?
No, you have to prevent.
Oh, absolutely. So what we have actually done is, what I've shown you right here through distortions is we've actually priced primary care out of the marketplace. From 1965 on, what we started doing is taking the lowest common denominator, which is the private family doctor, and price them out of the market so that you weren't making any money. And that, my good friend highlighted about the committee that readdresses CMS, but CMS redirects the reimbursement rate for medical. There's a reason I brought up dentistry. Can you tell me about the inflationary aspects of dental costs over 30 years versus medical costs over 30 years? Inflationary. Which one's higher?
Dental costs have stayed much more in line with inflation.
That's right. In medical, more than 20 times. What's the thing that's interesting about the two healthcare models? One has lots of federal government, almost entirely federal government, and one has very little federal government. Wouldn't you say that, Dr. Thomas?
Yes, but the nature of dental care is largely preventive and not anywhere near as expensive as the medical care system. So I don't think you can compare apples to oranges.
Oh, yes, we can. Oh, absolutely. It's paradox that we do this because in the dental model, there's many more primary care physicians than there are specialists. Today, what we've done is reinversed the whole payment model to be a specialist, not a primary care doctor. That's key, yes.
If I could just quickly add one additional point to what you're getting at. Dental schools and medical schools. Dental schools are closing, and there's less availability of dentists. That, too, is affecting the market. I would say a similar kind of restriction also exists in medical care, in the sense that you still have an entry barrier in the license to provide service, and I think the combination of those things are also increasing the cost, and it's another area where government could intervene to reduce distortions.
Oh, absolutely.
I think the gentleman, suffice to say that the Affordable Care Act does not have preventive dentistry in it, which perhaps was one of the mistakes. And with that, we go to the gentlelady from New Mexico.
Thank you, Mr. Chairman. And I really appreciate this hearing. I think it is demonstrating on both sides of the aisle that these principles. One, the healthcare system is incredibly complicated. So complicated, in fact, that when each of us are identifying situations, historical facts, trending spending trends, it is very difficult to say whether that is a private market issue in and of itself or a government issue. Some of the best programs that are the most cost-effective are where the government and the provider system, whether that's local or federal, are effective. That partnership is effective. When it's not effective, you have all kinds of things, and we can point to, and members have done this throughout the hearing, demonstrated that the private market, the insurance market on its own, certainly hasn't solved any of these problems and has gotten increasingly more expensive. So has the provider system. The government systems we can talk about, they've had fluctuations in productive outcomes and not so productive. Some states have great public health outcomes, some states do not. So for me, I think that I've sort of changed how I want to approach the panel. One, I agree with the chairman that we need to do much more in transparency and being able to apples talk about those effective investments, whether that is policy, regulatory, oversight, transparency, marketing, consumer protection. It's all of those. I do want to point out that in the conversations that we've had about life expectancy, what we haven't talked about is what sort of investments public health has gotten at the same time. Because if you look at sustainable, effective, that's both in terms of amounts and what they're directed at in public health, because states also make significant public health policy decisions, although the bulk of their money largely comes from the Federal Government, because states haven't picked up that role, because in the United States, we don't put a lot of credence in public health, which is the largest effort we could take to do productive, low-cost preventative care. And while there are incentives to do that in public and community health in the Affordable Care Act, we will have to see whether it's frankly enough, because like in all of the things that we've done in the United States, we have 7, 8, 9, 10 independent systems of care that we try to then roll into one and try to make sense out of it. And I don't think that you can. And where we go from here, I think this committee and others are going to have to play a much more significant role in getting that addressed. And so maybe, given that I've only got a couple minutes left, I just want to sort of re-ascertain a couple of things from the panel. One, that the private market by itself and all of those aspects that I identified, insurance companies, providers, hospitals, for-profit, not-for-profit, by itself has not been able globally to do any of the things that I just described: provide access, lower cost, improve outcomes, provide consumer protection, and affect policy in a way that would be meaningful, from oversight to better regulatory reform. True, not true?
True.
I would say not true.
Okay.
I would say not true.
All right. And I believe that it is true. And I've got 30 years. I don't have any of your expertise from your particular aspects, but I navigate healthcare even in this job every single day. And no matter what, it is getting increasingly more complicated. And I would submit that if any of you have, does anybody on the panel have a member, a family member on Medicare or Medicaid?
Yes.
Oh, my family members are in France.
So arguably better than Medicare. So the two that have family members on Medicare, if Medicare was gone, would you be able to provide finance that family member's health care on your own?
Absolutely not. Both my parents died of cancer, and their care was subsidized completely by Medicare, and they would not have been able to have that care without Medicare.
I don't think we simply don't know what the system would look like without Medicare. So you're asking me for an imaginary world that I don't have an option of really choosing.
Right. And I'm almost out of time, but also the reality is, and that's really my point, that we know that none of these systems are sustainable as they are. We know that without Medicare, the private market rates would be much higher, because we'd have to figure out what we would do with all of those elderly, sick people who would also be increasingly accessing emergency rooms and hospitals without any primary or preventative or routine care, and that's before you get to their acute care, chronic care issues that are covered by Medicare. We have to start figuring out how all of those systems impact the private market, or the lack thereof. The sicker people are in the private market, the higher those costs are. The higher those costs are, limited access to providers. Rural and frontier states are a whole different issue. So now that I'm out of time, and I really appreciate the Chairman's support, I would love to see this committee do lots more in transparency. I would love to talk about the models for dental care. There is, in fact, oral health care in the Affordable Care Act. It's pediatric. We're really going to have to talk about better integration for all of these models, and I would support the Chairman and this committee spending much more time in health care issues such as this hearing than not. So thank you very much.
You get a qualm for me at all. So I'd like to acknowledge the gentleman from Oklahoma, Mr. Lamford.
Thank you, Mr. Chairman. Thanks, y'all, for the time and the conversation. Can we agree on a principle that is economic-wide, I guess, or economy-wide, and that is fair competition is better for the consumer than price controls?
Yes.
Can that translate into health care?
Yes.
Yes, it can.
So then the challenge is, how does that get managed? If the goal is the benefit to consumer, the patient at this point, and to provide fair competition, and to provide multiple voices and as much transparency as you can have in it. There are some issues that are coming up currently right now with our system that get in the way of that. For instance, I know the Chairman mentioned earlier this issue of testing reimbursement. If you do right now in our system, according to CMS, if you do a histology test, a testing for skin cancer, whatever it may be, outside of a hospital, your reimbursement is 50% less than it is inside a hospital. So the incentive there is to do all the testing for the hospitals inside because their rates weren't cut for the big hospitals. They were for every small lab all around the country by 50%. Does that promote fair competition? Is it cheaper to do that test in a hospital, or is it less expensive to do that test in an outside lab typically? I would submit it's probably more expensive to do it in the hospital. I don't know that anyone would disagree with that. They're also reimbursed now 50% more. And so there is this, again, leaning into the larger hospitals. In the Affordable Care Act, it caps the growth of physician-owned hospitals. It set a date for them and said, however many rooms you have at this point, you have to remain at that. So physician-owned hospitals are at a permanent disadvantage to the hospital down the street forever. Is that fair competition? Does that benefit the consumer? Does that help us in price and cost and benefit consumers? I don't hear anyone saying that would benefit the consumers. No. So
there have been some problems with physician-owned hospitals that are part of why that measure was passed, but I won't.
Was the problem with the patient, or? Because 7 of the 10 top hospitals in the country are physician-owned hospitals, even still right now. But all of them will be capped in the days ahead and refuse to grow. They can't expand. So while patients may choose to do that, the Affordable Care Act steps in and says, no, I don't want more competition. I want less competition. To me, that doesn't benefit the consumer. That doesn't benefit, in this case, the taxpayer even, who's now paying the bill on it, where we're going to pay a higher price at a hospital than we would in a lab. We're going to pay a higher price in this facility, this one. And I'm not denigrating those. It just is a step into it to say we want less competition rather than more, and that doesn't seem to work anywhere else. Durable medical equipment right now, there was a decision by CMS to have fewer companies provide durable medical equipment because it's easier to oversee fewer companies. A large central government can't oversee thousands of durable medical equipment companies, so you need to have fewer companies so the Federal Government can oversee that for fraud. Right now, our payments out to companies where we can't verify or individuals, not fraud, just inaccurate payments, we're topping $50 billion in inaccurate payments through Medicare and Medicaid at this point. Can you make that more efficient by putting the controls for that closer to the payment location, closer to those individuals? So that may be a state that oversees that rather than the Federal Government, so they're not having to track it from Washington, D.C. Does it make it more efficient to oversee those things from a state or local municipality, or to try to do it all from a central location?
The state would make more sense.
So if we're going to go after inaccurate payments, is it better to make those decisions closer and check for fraud and check for inaccuracies closer rather than a centralized location? Seems like everybody's on board with that. These are some of the challenges that we have. And while we can talk about some of the healthcare issues, there's a basic principle of economics that we want fair competition and we want increased competition. And the Affordable Care Act is reducing the number of opportunities out there, reducing the number of places. So we're actually reducing the amount of competition. And we're saying in every area of the economy, free and fair competition works well, except in healthcare where we have to have more price controls, because that's quote unquote different. In Oklahoma City right now, we have 2 hospitals that have all of their prices online for their procedures. It started with 1 hospital that did it. And the push to get all your prices online has now pushed another hospital to say, okay, we'll put all of our prices online as well, and be able to detail out. What was interesting, the first hospital that did it, I talked to the gentleman that runs the hospital. He said, we were surprised when we put all of our prices online. Guess who came first? The Canadians. The Canadians came first to our hospital. We suddenly became a spot for medical tourism because they were tired of waiting 6 months in Canada for a procedure, and so they would fly to Oklahoma City, have the procedure done there when they knew exactly what the price was, and to be able to fly home. It's the same thing that's happening right now in our Veterans Administration. I have veterans call my office all the time that it takes 6 months for them to get a knee replacement, or they could cross the street and go to a fantastic hospital at OU Medical Center and get it done on Tuesday. But for some reason, we have this concept that we've got to do price controls and got to do central control because this is health care, when in everything else, it seems to work well with free and fair competition. We've got to find a way to do this. Integris Hospital in Oklahoma City is one of the best transplant hospitals in the world. Fantastic facility, incredibly well run. People come from all over the place to come to it because of the quality of the services and the openness of what they do. We've got to be able to push back on some of this. With that, I yield back.
Well, I want to take off on that for a second. Could you explain to me, Dr. Thomas, that why a procedure done out in a family doctor's procedure under Medicare is billed under Medicare Part A, but then the same procedure by a physician under a hospital is billed under Medicare Part B? It doesn't. You can't defend that. And that's what's happening, is we're allowing willy-nilly these rules to be unequivocally violated right and left. It's the same procedure. Buildings, each office has their own space to have to look at an overhead. So there's no reason why you have to allow hospitals to get reimbursements that sometimes double the price of a Medicare Part A aspect. One other thing that I wanted to highlight in your earlier testimony, it's not just about emergency rooms, is it, about access to care? I thought that was under federally qualified health centers, that your ability to pay could not stem you from not getting treatment. Is that true? Federally qualified health centers have a sliding fee scale in which they have to see you based upon your ability to pay. It is. Okay. I mean, I served kitty corner for one for many, many years. So there's more opportunities out there than meets the eye. Next question. The gentleman from California, Mr. Cardenas.
Thank you very much, Mr. Chairman. I'd like to thank the panel for availing yourselves to this committee so that we can hopefully improve on our understanding of what's going on with health care in our country. But there's been a lot of discussion today, and I guess rightfully so, because the hearing title is The Limitations of Big Government, the Rollout of HealthCare.gov. So a lot of discussion has been about government and whether or not government has a role. But earlier in a discussion, as a result of a question from one of my colleagues, the three non-healthcare expert panelists, all of you seem to agree that the private sector is more efficient than government when it comes to involving providing services and or systems to Americans. Is that consistent with what your answers are today?
When the goal is to provide a economically efficient product or service, yes. You have to be very clear on what you're trying to do. In other words, the market is not great at necessarily providing some specific targeted service to a particular individual who can't pay for it. The market may not do that. So again, you have to be very clear on what your objective is. But generally, if you're talking more about the efficient production and provision of goods and services, yes, I think the evidence is overwhelming that the market is superior for government. In fact, government rarely corrects those problems.
Any of the other panelists want to clarify?
I would pretty much agree with that and clarify the point that, certainly the market, I think, has proven itself to be able to lower costs and have more innovation. I think it's incredibly important to parse out that a lot of times what we're talking about is an income problem. And again, as I said earlier, all resources have costs. If someone has zero income, that's not a market failure. They can't afford those goods. You could make the same thing about government. If you had a group of people with zero income, obviously they can't pay taxes to support government either. We don't call that a government failure. So I do think we need to separate out the difference between, are we talking about a problem that's purely of poverty? Are we talking about a failure of the healthcare system? And those are two separate issues, and I think we combine them, quite frankly.
I agree with what has been said, but I would like to add that government very often, even when there's, let's say, we see a role like providing health care for low-income people who couldn't get it on their own, doesn't do that very well either. I mean, we've been talking about expanding Medicaid, but there's been no discussion about
health outcome for people who are in Medicaid. And a lot of the things that I've read, whether it was the Oregon study, and is like it's not a desirable outcome, or it could be improved. And I think we need to also talk about outcomes versus just providing delivery.
Well, I just wanted to clarify, and fortunately, you do provide us, all three of you do provide a service when it comes to the exercise of trying to understand where government should or should not be playing a role. However, the fundamental problem that we have in this country with the private sector is that the private sector has the right to ignore who they serve and where they draw the line at how much they're going to charge or not serve at all. Yet in our government, in this country, in many cases, the government has passed legislation and created laws that say we are not going to ignore. For example, an extreme case is when somebody shows up to an emergency room in this country. I don't know how they do it in other countries. It's a big world. But in this country, if somebody shows up in the emergency room, that provider of service, private or public, is required to stop the bleeding, regardless of the cost and regardless of the ability to pay. And that's the fundamental difference that I have with having a discussion that tries to have a purity of discussion about how government doesn't have a role in X, Y, Z, yet at the same time the private sector would do a better job or perhaps would provide better. But the fundamental problem that we have is, especially when it comes to health care, the private sector has the right, insurance company A has the right to tell person B, if they approach that company and say, I'd like to apply for insurance, they have the right to say, we checked all of what we provide. We don't have we cannot provide service for you. We're not going to insure you. They have the right to do that. And fundamentally, we have anywhere between 40 to 50+ million people in this country who, some of them fall into that category that no matter how hard they're going to try, the private industry is not going to provide for them. And that's where the Affordable Care Act is trying to thread that needle and saying, is there a way in which in this great country we can actually provide that to some of those 40 to 50 million people, and not all, to some of those 40 to 50 million people that on the natural, as the system is before the Affordable Care Act is in full bloom, that those private sector corporations have the legal right to say, sorry, we don't have a policy for you. Go to the next place or do whatever you wish, but don't come here. Is that an accurate, Dr. Thomas, is that an accurate portrayal of what one of our dilemmas is right now in this country that we're trying to tackle? I'm out of time, so, Mr. Chairman, they're welcome to answer the
witnesses answer if they'd like to answer.
Thank you very much.
What you are characterizing is something what we call in economics called merit goods. That is, these are goods that American society believes, goods and services, that people are entitled to regardless of whether they can afford them or not. I think what has changed over time is, yes, the government can step in and say, given democratic outcomes, we support the provision of these goods or services. We are now discussing and thinking about, okay, given that that is the case, what is the least cost way of providing those goods and services? I think historically people might think it's through the government. So the question about Medicare is saying, if we didn't have Medicare, what would happen to people? You have to construct what we call a counterfactual. That is, really construct what would have happened in the absence of the policy. So increasingly people are saying, Marty Feldstein is most notable, saying, if we had private health accounts, that might be able to achieve the goals that Medicare is trying to achieve at lower costs. And I think the questions we're raising about ACA, and I think the debate will follow again, universal coverage, fine. What now is the least cost way of doing that? That's what I think
Mr. Chairman, if I may, I appreciate that accurate portrayal of arriving at ideal solutions. But unfortunately, we live in a very dynamic, humanistic world where ideal solutions will perhaps never be attained. Thank you.
I thank the gentleman.
I yield back.
I'd like to recognize the gentleman from Pennsylvania, Mr. Cartwright.
Thank you, Dr. Gosar. And I want to thank the Chairman and Ranking Member Cummings for putting together this fascinating panel and allowing this interesting philosophical discussion that we've been having. Also, thank you to my colleague, Mr. Cardenas, for weighing in on that as well. For my own part, I will say, I think the government of the United States of America has been responsible for some of the most innovative and successful programs the world has ever seen. When we talk about Social Security, we talk about a program that has lifted people out of poverty, as you have said, Dr. Thomas. When we talked about Medicare, the same thing, a program that has enabled regular people to avoid medical bankruptcy, to qualify for treatment, as in the case of your parents, Dr. Thomas. And so many Americans depend on Social Security and Medicare. I will be an unceasing advocate for both of those programs, as well as other Federal programs. Our interstate highway and rail system transports millions of people daily safely. The Environmental Protection Agency ensures clean drinking water and breathable air for Americans. Our brave soldiers in the military put together a program that is the envy of the free world, our American military, our soldiers and sailors. The Consumer Product Safety Commission ensures that Americans feel secure in their purchases. The Federal grants, loans, and work-study funds that provided to our students enable higher education to become a reality for millions of Americans. And then when we get to this ACA, absolutely, it's been a rocky rollout, and in my view, we're going to have further work to do on it. We may well be tinkering with the ACA for years to come. But my view is, and my prediction is, that history will look kindly back on the Affordable Care Act as just another in a long line of examples of American greatness. And Dr. Thomas, I want to follow up with you. I'd like to ask you about Social Security a little bit. You touched on it. The implementation of that program was hugely controversial at the time in the 30s, and not without its own challenges. But today, like Medicare, it is obviously an extremely admirable, successful, and popular program. And I have an article here that was published on October 28, 2013, and it's entitled, "What About Social Security's Rollout?" Dr. Gosar, I ask unanimous consent that this article be inserted into the public record. Dr. Thomas, this article describes many of the problems facing Social Security in its first several years, and it compares them to what we are seeing now in the ACA. For example, the article says this, and I'm going to quote from it. After the nation's major social program finally became law, critics regularly blamed it for slowing the economy and a swelling of the Federal bureaucracy. Fierce congressional opposition led to the formation of a blue ribbon panel to overhaul Social Security. Obamacare in 2013, not quite. It was Social Security in 1937. Dr. Thomas, it seems obvious, but would you agree that the implementation of a large-scale Federal government program like Social Security takes time?
I would agree, and I would also add that anything that's ambitious that will actually enact real change is bound to encounter problems.
Well, I want to go on quoting the article. Created in 1935, the Social Security program took 40 years just to include all working Americans in its basic coverage. When old age insurance program launched in 1937, barely more than half of the labor force participated. A series of amendments to the Social Security Act gradually expanded the coverage, and by 1979, it finally reached over 90% of American workers. Now, Dr. Thomas, the history of Social Security implementation seems to support the idea that the government is, in fact, capable of effectively administering a large-scale program like this that helps millions and millions of Americans. Would you agree with that?
Yes, the administration of the program has has evolved over time, but is certainly working smoothly at this point. And Social Security has evolved over a period of more than 70 years. And for instance, the amendments to include domestic and agricultural workers to make sure that they were covered, they weren't passed until, I believe, 1950, because there was such political opposition in the South previous to that when the law was passed originally. So over time, new priorities are brought into the law that improve its function.
And I say, let's work together and improve the ACA and make it work for us over time. And with that, I yield back, Dr. Gosar.
Well, I want to let Dr. Ruge kind of answer a question. She wanted to answer one of your questions.
What I wanted to say about Social Security is, and that's one of the problems was government. It's like sometimes government creates a program because there is an actual need. And the problem is like you then go back 60 years later and that need may not be there for a majority of the people it serves, but then the problem stays in place. And that is one of it's the case. I mean, like 15 federal agencies have run a state of seniors in America right now, and you can see that their conditions is dramatically improved. And yet this program still serves everyone as if everyone is in poverty. The other thing I would add is that if Democrats are like Social Security so much, why not try to reform it? Yeah. This is a system that's bankrupt in 2035 and probably before. When the trust fund expires, the prediction is that benefit will have to be cut across the board by 25%. The people who will be hurt the most are the people, the seniors who at the time still actually are poor. And I want to say, if we think it is a program that provides a valuable service to seniors who are poor, why not reform to make sure that when that time comes, they will not be the one hurt the most?
Dr. Winston, did you want to make a comment? No. Okay. How about you, Dr.
I was going to add, Veronique touched on this, but I do think, we've talked about the benefits, of both Medicare, Social Security, and these programs. But again, as mentioned, and I'll echo something that the gentleman from Illinois, Representative Davis, said about the young and the elderly. Programs that leave trillions of dollars of debt for the young to pay off, programs that make promises to the elderly that cannot be kept, that's not compassion, in my view.
That's creating cripples. I just want to ask you, Dr. Thomas, I got a few extra minutes and the privilege of sitting in the chair. Are we healthier as a nation right now?
Healthier than when?
Oh, let's talk about the 30s. Rising rates of diabetes. Was diabetes as high then as it is now?
We have dramatically improved life expectancy.
Let me ask you another question then. So let me ask you another question. Compared to other industrialized nations, how healthy are we? Let's compare diabetes.
Well, I can tell you off the top of my head that the infant mortality.
No, we're not comparing apples to apples there. I'm not talking about.
No, I'm going to agree.
I'm going to talk to you about obesity.
Okay.
Let's talk about obesity. Let's not change the subject. Let's go directly to apples. Obesity.
Fortunately, the obesity epidemic has leveled off and is beginning to improve. But yes, that's a major healthcare problem.
Yeah, I would disagree on that. Diabetes.
Also a major healthcare problem.
Absolutely. And so I want to bring you back to
talking about diseases of affluence.
What's that?
They're diseases of affluence.
I don't know about that. Good eating policy. I'm one of those guys. I'm celiac sprue, by the way, so I'm allergic to wheat and glutens, and that's why I'm kind of the incredible shrinking guy. But we have to have patient accountability in this process. Just for example, for me as celiac sprue, I have a 7 to 8 greater chance of getting any type of lymphoma. Okay, so what we want to do is have prevention. So what I want to see is I want an insurance company to come to me and say, listen, Dr. Gosar, we know that early detection of lymphomas is the best way and the cheapest way. So we're going to give you some incentives to come and have a physical twice during 3 years. And if you do that, we're going to give you a kickback for doing that. You re-incentivize good behavior. Right. It's like our eating, our SNAP program. I have some problems with our SNAP program, don't you? All the sugary stuff on those. You're public health. Come on now.
I would definitely like to improve
So,
that.
so okay, so tell me what's on the WIC program that everybody shouldn't be on. Women, infants, and children, you know, complex carbohydrates, complex proteins. Why shouldn't we be all on that?
Well, some of us can't eat that without getting sick.
Name one. Name one on the WIC diet that you won't get sick on. I mean, if it's good, I'm cautioning you once again.
I don't.
This is my forte. So if it's good enough for women, infants, and children.
Give me some specific examples.
I'm asking you for specific examples. You said that we
I don't
all
have
eat
the
them.
WIC formulary in my head, I'm sorry.
Oh, it's complex proteins and complex carbohydrates, so there's no simple sugars, maybe outside of a few fruit juices. I think if we're on government's assistance, we should be all on the WIC program. Don't you think? If it's good enough for women, infants, and children, I'm just telling you. Those are the weakest. That's one of the groups that was highlighted today, one of the weakest groups here, that if it meets the criteria of meeting that formulation for.
But they have different nutritional needs than everybody else.
Not necessarily.
I'm not sure where you're going.
No, not necessarily. Can you tell me the public health mantra, was it a success in Indian Health Services? I mean, we heard about the integration for the African Americans. Tell me about the Indian Americans. It was a disaster. It's not been great. In fact, part of the trust obligations from the Federal Government was to work in concert with the tribes, not to dictate to them. Isn't it true that the tribes have an option out of ACA because of self-determination, and they're taking it? They're actually building their own hospitals. They're doing their own thing because they want to breed the aspect of prevention and patient accountability.
And you say the Indian Health Service has not done that?
They haven't. I mean, I'm from Indian country. I can tell you that right now. The Navajo Nation, the San Carlos tribes, they're all privatizing. Because what government came in and said, these are the services we're going to give you regardless of what you want. We're going to do this accordingly, and it was a failure. 30% of my patient base in my practice came to me to pay for my services because they valued them, because they could have got it free from the Federal Government, and they refused. There's something to learn from that experience there. And I hope that you go back and look at your notes, because some of the things you're citing aren't exactly factual historically. So, last comments, Dr. Ruge. I mean, you know, from the standpoint of this hearing, is there anything that you would like to comment in regards?
No. I mean, I think that we need to remember that even when the government is well-intentioned, a lot of the ways that it intervenes, it is actually goes even against the goal that they've set for themselves. And we also need to remember that it always introduces distortion, and that government officials, unfortunately, have a great incentive to listen to interest groups.
And so it's not about whether the government's involved, it's a balance, wouldn't you say?
Sorry?
Trying to find a balance of government involvement.
Well, I think one of the things that we've learned is like government fails, and one of the best ways to prevent them is to actually limit the purview of government intervention.
And maybe hold people accountable for things
Absolutely.
poorly done. Dr. Winston, final comments.
Yeah, I think my final comments are that an awful lot of the discussion in some sense has been looking backwards. There's been reference to history, Medicare, Social Security, things that have been done in the past. The world changes, and I think it's probably more important going forward, to start looking forward, the future, looking for new ways in which we want to try to do things, recognizing that, yes, maybe in a different time government was effective in doing something, initiate doing it, but things change. And if there are other ways in which we can try to achieve the goal we're trying to do it, particularly with the market, we should be experimenting and be more open-minded to the fact that we don't have to be wedded to the past and look for new ways of doing things.
Yeah, I like that aspect. You always have to look at your past before you go forward, because you're doomed to repeat the past if you don't. Dr. Calabria.
Well, I'll end with maybe summarizing a few points. And, the first of all is, of course, I think sometimes there's a bit of a straw man aspect to, the market not being perfect, government not being perfect. Of course, as we know, there are no perfect institutions. They all have their flaws, and I think we need to find the better that works out of any of those institutions. I'll reiterate a point I've made a couple times before, which is I do think that there's a confusion between what is essentially a poverty problem and a failure of various markets. If you have zero income, you can't afford anything. That doesn't mean that all of those markets are are failing. And again, the way to address that is to try to address poverty directly, which I'll say as an aside, I think the overwhelming evidence across countries and across history is if you really seriously want to reduce poverty, extending the market is the way to do it, and creating wealth in that regard. I will end, and finally, we often sort of hear a moral argument made. I will be very clear that my preference oftentimes for markets is not simply an issue of efficiency, but I believe that markets are by and large based on consensus, where I believe it was the gentleman from Virginia made the point about us not getting along. Well, the part of us not getting along is you can use the government to force me to do things I don't want to, whereas in the marketplace, for me to sell you something, I have to come to a price and agreement in terms of which you agree. So, my goal as a generality is, how do we try to build society more on consensus and cooperation rather than coercion?
And customer service. Dr. Thomas, your last comments.
Well, I would agree with, I believe it was Ms. Grisham who said that the health system works best when government and nonprofits and for-profits all cooperate in the most efficient way, and that is what I am advocating. And I also agree with Dr. Winston, who said, times are changing, and even as a historian, I don't think that we can do things exactly the way they did in 1935. But I think a sign that things really are changing is that the American Medical Association, which has opposed every national health insurance proposal since 1939, in 2010, supported the Affordable Care Act, and in fact, the AMA's executive vice president, Michael D. Maves, admitted that we don't believe that maintaining the status quo is an acceptable option for physicians or the patients we serve. I think that is a very important turning point that we're at.
I don't think anybody will disagree that what we had as status quo would work. I'm here because of that. I just don't think the solution that we have on the table works because we didn't get everything on the table put on the table. At that time, the AMA represented about 18% of all physicians across the country, hardly a vote of acknowledgement. And I think they're actually rescinding that aspect now. They don't particularly care about that, if I'm not mistaken. So statistics can be used a certain way. The last thing I would like to say, and I'm fleeting, is that when we look at problem solvings, we have to look at where our costs are spent. You made a comment about where we're spending a lot of money. In Medicaid and Medicare, the dual eligibles are the ones where we're spending the most money on. And these are problem solvings that we want the best of the best. And there's two pools. There's the seniors that are so poor that they're in Medicaid, Medicare, and there's the youngers that have real chronic conditions like multiple sclerosis and that aspect. It's ingenuity that sets us free. And that's why I came back to McCarran-Ferguson. I want to turn the insurance industry upside down. I want them to be revolutionized to compete for my dollars. Because I want new incentive programs based on me, customer service. That's one of the things that we got to get back to. Not government dictated, but good customer service, patient-centered, patient-friendly. And we put all the market factors working on behalf of people, not making them cripples, but to empower them to make health choices. They win.
But how can you turn that insurance industry upside down without an outside push?
That's why I said McCarran-Ferguson. I want choice. My choices are very different, as I elaborated, versus somebody else's. And so breaking up the common denominator, if I'm a group of, all of us are physicians here, we can't collude on prices, okay? But insurance companies do, okay? So what I want to do is I want to see the innovation within the insurance industry and show me what I don't even know. They're the experts in that. I'm an expert in dentistry. I want them to show me what is possible because I haven't dreamed it yet. Neither have you. Neither has anybody here. What I see at this panel is the people that bring the building blocks of what you can envision as success. And we haven't got it. And what I think we saw from this panel is government can't do that. When you talk about monopolies, non-competitive bidding practices, David Baker,